Good morning. We'd like to go ahead and start the hearing. We'd like to go ahead and get started if you guys could have a seat and we'll get going here. So first of all, thank you very much for being here. We are going to have our first panel come up in Mass. So that will be Mr. Lighty, Dr. Pollin, Mr. Fountain, and Dr. Tarzynski. If you'd all come up here, that's our first panel this morning. Thank you. And then we'll start with some opening remarks, and then we'll move right into the panel. So, so good morning, and welcome to the last scheduled hearing of the Select Committee. Following this hearing, we'll begin the work of developing our report, which will include actionable recommendations. We may need to reconvene additional hearings as we work through that process, but hope to complete our report by early spring. Just last September, Senator Bernie Sanders introduced his Medicare for All bill on the Senate floor and said this, quote, "The truth is, embarrassingly, that on this enormously important issue, there has not been the kind of research and study we need," end quote. Just yesterday, the United States of Care was announced. This new nonpartisan nonprofit headed by Andy Slavitt, who served as the acting administrator for the Centers for Medicare and Medicaid Service in the Obama administration, has convened a high-profile group of public health figures to reshape health care. It's one of the many different groups building and mobilizing a movement to achieve long-lasting solutions to ensure that every American has access to high-quality, affordable health care, regardless of health status, social need, or income. Amazon rattled the healthcare market a couple of weeks ago when it announced a partnership with Berkshire Hathaway, J.P. Morgan Chase, to create a nonprofit healthcare company focusing on cost reduction, increased transparency, and user satisfaction. Although no details have been revealed, it will be a force to be reckoned with. Here in our state, many organizations have been advocating for changes to the healthcare system. Healthy California, a very passionate group of advocates, along with CNA, California Nurses Association, has raised the awareness and certainly the decibels of this issue on behalf of all Californians, and we absolutely need to thank them for that. The answer should not be in politics, but in bringing together everyone with one goal. I can assure you that my goal has always been to find a constructive, affordable, and lasting approach. As I've said many times, I make no apologies for the amount of time we have spent on this complex issue. We spent more than 10 times the hours usually afforded a typical bill in a regular Assembly Health Committee hearing. 28.5 hours and counting today. Our work has been comprehensive and thorough. We must ensure that any significant changes to our healthcare system works for all Californians. It must be affordable, it must be quality, and it must be sustainable. No mistakes, no empty promises. On Monday, we learned about the many challenges we face in implementing significant changes to our system. And although they are not insurmountable, they will take time. And more than that, will take a change in the balance and power in Congress to get the changes in federal law that we need. Today's hearing will provide the opportunity for a number of organizations to present their plans for achieving universal health coverage, including the California Nurses Association, the California Physicians Alliance, Health Access California, the California Immigrant Policy Center, the California Labor Federation, and Small Business Majority. I want to thank all the committee members for their active participation over the past several months as we close in on a pathway to a healthcare solution for everyone who calls California home. And now I would like to ask my co-chair, Dr. Joaquin Arambula, to make his opening remarks.
Thank you. I'd like to thank everyone who is here today, and especially thank those in the audience who have attended or who have watched all 6 days of our hearings. I am particularly cognizant of our advocates and appreciate your dedication to this cause, knowing that it can be difficult for many of you to attend all the hearings in person due to other obligations. As a public servant, it's our duty to be a voice for the voiceless and I'm aware that so many from my community could not be here today. I will do my best to be their representative. Today's hearing will focus on proposals that can improve our state's health care system. We will hear from a broad range of interest groups that have ideas on how we can provide better access and better care. This committee's charge is to find workable solutions that will expand health care coverage and increase access to all Californians. A better organized system covering every Californian would almost certainly cut our health care costs. Every other developed nation spends less on their health care than we do, and with better health care results. We hope to find a system or systems that will provide coverage to all by examining the efficiencies and cost control mechanisms. Today, we will hear about opportunities to make our system more efficient. We know that people without insurance are less likely to get the medical care they need. The Federal Institute of Medicine put it succinctly: uninsured people are more likely to receive too little medical care and receive it too late. As a result, they are sicker and die sooner. I am convinced we can improve our state's healthcare system. I believe that healthcare is a human right, and I believe California can and must do better for all its residents. At the conclusion of this hearing, we will have a better understanding of the various pathways we can pursue to achieve universal coverage. And as an Assembly member and as a co-chair of this committee, I remain committed to helping people in the Central Valley and throughout California achieve this. With all of the controversy surrounding health care and what Trump administration and Congress are proposing and threatening to do, Californians are rightfully concerned about whether they can get and keep affordable health insurance, and whether there will be doctors and other professionals to care for them. The work we have done so far has allowed us to gather all of the facts about health care insurance in California, and will provide us the options that are available to us now. I would like to welcome the other committee members who are here to see if they have opening statements. But before I pass it on to them, I wanted to say that we will have 2 panels today, with 3 presenters in each panel, and following each panel, members will have the opportunity to ask questions. We are scheduled for a break for lunch from 12:30 to 1:30, and following the final presentation of panel 2, we will provide time for public comment. Our goal is to ensure we allow as many people to speak as possible. Please be respectful and limit your comments to 2 minutes if possible. When you have exceeded the 2 minutes, we plan to turn the microphone off, only so that we can make sure to allow as many people to speak as possible. More detailed written comments are always welcome and can be submitted to the committee. With that, I'd like to turn this to the other members on our committee to see if they have opening statements.
Thank you, Mr. Co-Chairs and committee, and to everyone that is here. This is a big issue. I won't belabor the point. It is basically the committee where rubber hits the road, I think, and every question that needs to be asked will be asked, and I look forward to our discussion.
Similarly, I'd like to thank Dr. Wood and his staff for all their hard work in bringing so many different stakeholders together for these incredibly important hearings. I'd like to thank Dr. Arambula and members of the committee. I appreciate the dedication. I know this is we've been discussing this for hours upon hours, and there's never going to be enough hours to really have this conversation, but it's an important conversation, and I appreciate your insight on a lot of these issues. I also would like to thank every person who has come out for every select committee hearing, those that have provided their expertise and those who have just spoken and shared their stories. As we've learned over the last couple of months, nothing is more important than finding a path to complete coverage for all Californians, especially our most vulnerable populations. And that comprehensive plan must provide better outcomes than our current system is providing. When we come to an agreement, which I believe we will, it will take months and years to implement, and I've heard your testimony, and I have heard so many of you talk about people are sick and people are dying now. I am deeply concerned about those who need our assistance today, and those who are currently underinsured, which we have learned so much about here in this committee. I believe it's imperative that we find both short-term and long-term solutions. I know that even if we pass something immediately and it was signed for urgency, it will still take us time to implement. And so I'd like to thank CNA and all the attendees who have shown up for the hearings, made your calls, written your letters, knocked on doors. I appreciate you bringing this conversation to the forefront. It's important to me personally. I have been an uninsured person, and I have been a sick uninsured person. So I think on this committee there's probably no one that it is more personal to. So I really do. I thank you for your commitment. I thank you for your drive. I thank you for bringing this to the forefront. And I do thank you, committee members and those who have spoken and educated us on your time and your effort.
Our first presenters today will be the California Nurses Association, Michael Lighty, Director of Public Policy for CNA, Dr. Pollin, Professor of Economics at University of Amherst, and Stephanie Roberson with CNA as well.
What's that? Yeah, we're good. Okay. So my name is Michael Lighty. I'm here on behalf of the over 100,000 members of the California Nurses Association to present our proposal for guaranteed health care. We are not presenting an option for universal coverage. Coverage is not care. Access is not care. This is a proposal for guaranteed health care because it addresses the #1 problem facing Californians. Will we be able to get the health care we need when we need it, or will there be barriers in our way? SB 562 eliminates those barriers. It is guaranteed health care. It is not coverage. And the reason we take this on is because the healthcare system has become an industry where money is the metric of good medicine. The caregiving profession that the members of CNA were educated to do has been overrun by the profit motive. This has resulted in huge out-of-pocket costs. 36% of Californians face an underinsurance epidemic. 15 million Californians are either uninsured or underinsured. If you have a medical expense of over $1,000, 39% of us can't afford it. The individual premium is immense, but it's subsidized by taxes. Our taxpayer dollars are going to subsidize the failed business model of the insurance industry, and what they do is they organize the system as an industry, they restrict access, and they use that to profit based upon claim denials and other practices. What do people care about? They care about just what you're saying, Assemblymember Burke. Will we get the health care we need? It is the most intimate experience of our lives where public policy meets our everyday reality, and yet we are subject to the practices of the insurance company. We do not control our own care. The deductibles and other cost sharing are increasing. Can people go to the doctor that they need to, or is that doctor out of network? Will they have high fees? These are the problems SB 562 addresses, and that simply providing insurance to everyone will not address, will not solve. Look at the 43% of Americans say they have trouble paying their deductible. That's nearly half. And here is we get to the crux of it with the insurers. Denial of claims is their business model. In 2009 and 11, we did a study, and then by the time we completed that study, they've now closed off access to data on claims denials. So we have to look at the independent medical review process to see how they're denying claims. Back in 2011, we saw 24% of all claims were rejected. They're doing that because they need the profit. Now we look at independent medical review to get a sense of claim denials now. Look at that. Almost 60% care denied is not medically necessary, but ultimately most of that 60% rather, was in fact overturned because those care denials were illegitimate. Payment denied, again, mostly overturned, illegitimate denials. These insurers in California have made $27 billion in profits, net income. Why are Californian workers and businesses paying for the profits of the insurance company when they add no value and deny us care? And then the penalties that have been assessed are a fraction of what they've actually incurred as profit. Look at the profit per enrollee. Anthem, $175 per enrollee in profit. No, that is dollars not spent on care. This is really the tip of the iceberg, this denial model. And here we have the basic point. Universal coverage is not guaranteed health care. And if we continue to enable care denials and use our tax dollars to subsidize the failed business model of the insurers, we are wasting money. Similarly, it does not make sense to just subsidize the purchase of private insurance if that is not going to enable folks to get the care we need. Universal coverage is not a solution. If we underfund and limit the scope of safety net programs like Medi-Cal, that fails as policy and ethically. So we want to turn to SB 562. It's a model of social insurance where everybody's in, nobody's covered. We replace those rising premiums with public financing. We eliminate deductibles and copays so the out-of-pocket costs are no longer a barrier to care. Providing insurance won't do that. Complete choice of provider, comprehensive benefits, no cost to access care, no financial barrier to care. It's a public solution. Enrollment's automatic. Everybody in, nobody out. And of course, there's a role for supplemental benefit programs. If we look at Healthy California, the Healthy California Act specifically, we see that it guarantees health care to all Californians, all residents of California, regardless of immigration status. There are a number of reasons to do that, but the most important reason is we need to establish a single standard of safe therapeutic care. That is the only way to initially address healthcare disparities, because in the current system, the kind of health insurance plan you have, the kind of benefits you get, whether it's a platinum plan or employer plan, determine the standard of care you receive in California hospitals. That not only is your benefits based on ability to pay, but the actual standard of care you receive. The only way to eliminate the health disparities based on race, gender, and income that exist is to establish a single standard of safe therapeutic care by including everyone. We eliminate the bureaucratic waste and inefficiency in marketing costs. We go to the doctor and provider of our choice. That's a fundamental principle. No other reform that's insurance-based can do that because they always have networks of providers. That's how they save money, is they contract with providers at a lower rate and limit people's ability to go to alternatives. And when you do go out of network, it's 40% more expensive. So we eliminate all that and still complete provider choice. We want doctors and nurses and clinicians in charge of our health care, not insurance company bureaucrats. SB 562 does that. We establish progressive payroll and income premiums, call them taxes, call them fees. Dr. Pollin will discuss that. And we set up an independent health authority that is the Healthy California Trust Fund. And that trust fund is what pays providers. And we're able to pool all the monies, and we can get into the discussion of federal waivers and so forth, and then we're able to pay providers based upon Medicare rates. That is a substantial savings and a seamless integration with Medicare. And that independent public health authority then pays those doctors, clinicians who are in charge of healthcare services, because there are specific provisions in the bill that prevent professional clinical judgment from being overridden by technology or standardized protocols. So imagine a healthcare system where doctors and nurses and clinicians are in charge, that saves businesses and individuals billions of dollars, that provides comprehensive benefits to everyone regardless of ability to pay. That's guaranteed healthcare. It's not universal coverage. For labor, that means that workers can change jobs without losing insurance. It means that we can have comprehensive benefits without having a $2,000 deductible or a $1,400 deductible. That's the average deductible in large employer plans. 39% of Californians do not have $1,000 in the bank for a medical emergency, and yet we're expecting them to pay a $1,400 deductible. There's no other proposal on the table that eliminates deductibles and copays. You have money saved from lower health care costs that go to wages. We can incorporate retiree health benefits into this program. That's a voluntary process under SB 562, but we would be able to eliminate the state's unfunded retiree health liability that exceeds $80 billion. We can take that over with 562. The current system for business is unsustainable. They're in the healthcare business when the healthcare insurance industry provides no benefit to their bottom line. So they would very much desire to get out of that business. We estimate, Dr. Pollin will talk about this, a third to a half reduction in cost to employers, that the employer's premium payment, call it a tax, call it a fee, for Healthy California is relative to the scale of their enterprise. No longer do small businesses get asked to spend $20,000 a year on insurance premiums, regardless of their ability to afford it within their business model. Now we're going to be able to have them pay for health benefits according to the scale of their enterprise, so it's relative to their revenue or to their payroll. That's much more fair and equitable. And then, of course, real healthcare cost control means value for businesses so they can innovate and grow. That's what our healthcare system currently prevents, is that basically the really strength of the California economy is undermined by how we pay for healthcare. When we talk about guaranteed healthcare, it's important that we understand that what provisions of the bill exist. Every resident of the state shall be eligible, entitled to enroll. Sets a single standard of safe therapeutic care for all residents. That's the primary program standard in law. The prohibition on overriding clinicians' professional judgment is enshrined in law. If we are committed to making healthcare a human right, then we can't let that be conditioned by insurance company denials, by ability to pay, or by limitations on what providers consider medically necessary treatment. That's the only way to establish healthcare as a human right, is to guarantee it for all and not establish those barriers. So we eliminate those premiums, copays, and deductibles. We also have a provision that Dr. Pollin will talk about of alternative funding mechanisms. When we talk about going to a provider of your choice, we're talking about this being also care delivered in the most clinically appropriate setting. That is not the basis in the current system. The current system is we'll provide care in the least expensive clinical setting. But doctors and nurses know that there's a difference between what might save the hospital corporation money and what's in the best interest of the patient. So we require, as a matter of duty for physicians and others, patient advocacy. So any of the financial interests they may have in a, say, in an outpatient surgery center cannot override their duty to advocate on behalf of their patients. As I say, it's the intent of the legislature that we cannot override the effective judgment of clinicians. Here's the list of the comprehensive benefits. That includes reproductive health services. You'll notice it includes some long-term care services that will no longer be means tested under SB 562. That it's dental and vision. This is more comprehensive than any of the plans out there now and at lower cost, as Dr. Pollin will show. This is an independent healthcare authority. As I said, the trust fund is created and established by the board, and it will be mandated to have a prudent reserve. You asked us to address governance. This is the governance structure for the board. 9 members, 4 from the governor, 2 from the Senate, and assembly with the Secretary of Health and Human Services serving as a ex officio. And they have to have demonstrated expertise in healthcare. Essentially, what we're doing with this process is we're creating a single pipe where we take all the revenue from existing federal and state sources, put it through a single pipe or channel, and then we're able to pay providers based on that pooled resource. We eliminate care denials and restrictions. There's been a question about how do you ensure that service delivery will occur. What we're doing is we're stopping those denials and we're eliminating gatekeeping and narrow networks and the financial barriers to care, but it's a mixed payment system. So some providers will be paid on fee-for-service, some will be paid on a per capita basis, some will be paid on an operating budget basis. And we're leaving that up to the board for flexibility to determine the most efficient way to do that. But in doing so, we're able to, because everyone's in one system, have data collected based upon outcomes and procedures and practices and use that data so we don't have to deny people care up front. We can review practices, identify outliers, identify fraud, and after the fact, and correct it going forward. We think that's a more efficient way, having saved money up front by public financing and everybody in one pool. We then are able to review quality care through the systematic data collection that we have established in the bill and ensure that there's no barrier to access. We do set Medicare rates as presumptively reasonable, and we negotiate from there. So for all services that Medicare covers, those rates will be the same as in California as in Medicare, and that they, as I mentioned, can be on a different payment methodology basis. We have to ensure adequate supply of physicians. Remember, we have a physician shortage regardless of what system we go to. This system improves the practice environment, stabilizes reimbursement, ends all the hassles that doctors experience, and guarantees reasonable pay in an efficient and timely manner. So it's a much improved system. The patient advocacy duty I mentioned, we preserve a role for Taft-Hartley Trust as part of our approach to care coordination, which the committee asked. We have an extensive ability to navigate through the system through existing relationships between patients and providers. So if you're in a county system now, that county system can be a care coordinator under Healthy California. They can help you navigate the system. They can track your medical records. So we use care coordination to help facilitate the efficient administration of Healthy California. And Taft-Hartley Trusts are one of those entities that can do that. We consolidate all state drug purchasing. We will apply for waivers. We have a procedure both to get those waivers and in the eventuality we don't, to make sure that every dollar that California is entitled to from the federal government we receive. It's specifically a question of how we channel that. We do have a just transition for displaced workers as well who may be lose work or transition into another job. I want to leave it there on time. What I want to leave it with is we have an opportunity to provide real health security and guaranteed health care. Most importantly, peace of mind for Californians. That's what SB 562 promises, peace of mind. Thank you. So you're up.
Can I just start? Yep. Okay, I'm Robert Pollin, and I'm a distinguished professor of economics and co-director of the Political Economy Research Institute at the University of Massachusetts-Amherst, not University of Amherst. We're very sensitive on such things. I'm also former professor of economics at University of California, Riverside, where I lived in Riverside, raised my 2 children with my wife in Riverside, and have very strong connections and feelings, continue to, with Riverside. What I'm going to do is summarize right now some of the main findings of the study I co-authored with other UMass faculty members that was put out in May 2017. And in the interests of discipline and time, I'm basically going to read this summary. The fundamental purpose of Healthy California is simple: to create a health care system for the state that enables all California residents to enjoy decent health care as a right. This is certainly a laudable goal, but we still need to ask some hard questions. Is it realistic to be able to provide decent health care to everyone in California? And more specifically, is the Healthy California proposal a workable vehicle for achieving this goal? My short answers are yes and yes. Providing universal, decent health care is within reach in California, and for that matter, in the U.S. overall. And yes, Healthy California does provide a viable framework for achieving this goal. Lots of details will need to be filled in to make the proposal fully workable, but in my view, the basic approach is sound. In these remarks, I'm going to touch on 4 key issues. Costs of universal coverage relative to the existing system, potential for cost savings under Healthy California, how to fund Healthy California, and what the impact will be on funding Healthy California on the state's households and businesses relative to what everyone is paying now for health care. Now, before going into these issues, I want to just start by recognizing the 2 recent reports provided on the issue by staff members at both the Senate Committee on Appropriations, who released their report in April 2017, and the Legislative Analyst's Office, whose report just came out 2 days ago. These are both useful reports, in my view. I spoke with the authors of the first report, led by Mr. Brendan McCarthy, before it was released. I agree with about 70% of what's in both reports. Now, it's not totally surprising that I would agree. It so happens that one of my best students from UC Riverside, Mr. Robert Ingenito, participated in preparing at least one of them. Now, the most significant difference I have with these reports, as I will address below, is I believe there are large areas of potential cost savings that are attainable through Healthy California relative to our current system. I reached this conclusion not on my own, but through assessing the relevant research literature on these matters. Indeed, in working with this research literature, overall, we set our estimates of cost savings through Healthy California on the conservative side of what the literature thinks is reasonable. Okay, current healthcare system costs. For 2017, overall healthcare costs in California were about $370 billion. This was about 14% of the state's 2017 GDP. Healthcare costs in California are lower as a share of GDP than in the U.S. overall, in which the share is about 18% of GDP. At the same time, healthcare costs in all other advanced industrialized countries range between 9 and 11% of GDP. This includes Germany, France, the UK, Japan, and Canada. Overall healthcare outcomes in these other countries are all superior to those in California and the U.S. generally. At present, about 33 million people in California, 92.5%, are covered by some form of health insurance, while 2.7 million, 7.5%, are uninsured. One of the goals of Healthy California is therefore to provide decent coverage to the 2.7 million who are presently uninsured. These figures, of course, reflect anything before the repeal of the health care mandate at the federal level. But in addition to the uninsured, there are roughly another 34% who are what we could call uninsured. There is no single precise definition of underinsured. In our study, we took an expansive definition working from a survey conducted by the Commonwealth Fund, an outstanding research organization. This survey found that for the U.S. overall, about 36% of the population went without needed care because of cost considerations. The figure is modestly lower for California. These people, 1, did not fill a prescription, 2, skipped a recommended test or treatment, 3, did not visit a doctor even while having a health problem, or 4, did not get needed specialized care. This is our working definition of the underinsured population. There are other definitions, and we can go through them as you wish later. Okay, what are the costs of providing decent care for everyone within the existing system? Okay, we estimate that to provide decent care for everyone under the existing system, and now I'm going to include the 7.5% who are uninsured and the 35% who are underinsured. Under the existing system, where we're now spending $370 billion, we estimate that we'd raise costs by about 10% to provide decent care for everyone. That is, the overall system cost would rise to about $400 billion from the existing $370 billion. Just to emphasize this again, we are not going from 0 to $400 billion. We are going from 370 to 400 under the existing system. Note that here that our estimate is virtually identical to that of the Appropriations Committee report and the State Legislative Analyst's Office. Now, potential for cost savings. Working again from the existing literature and making conservative assumptions within that literature, we have estimated that Healthy California could generate a total of about 18% in savings relative to the existing system. Here's how we get there. We estimate 6.6% savings on administration system-wide, 3.4% savings on lowering pharmaceutical costs system-wide, 3% savings on establishing Medicare rates for healthcare providers across the board, as Michael just referred to, and 5% savings through reducing unnecessary treatments, expanding preventive care, and cutting back on fraud and abuse. Okay, that's how you get 18% savings. Thus, when we cover everybody within the system, under the existing system, before savings, we go from $370 billion to $400 billion. When we incorporate the savings that are achievable conservatively achievable within Healthy California, total system costs will go down to $330 billion or thereabouts. Total system costs will go down from the existing $370 billion to $330 billion, and under the $330 billion with Healthy California, everybody gets decent health care. Now, how do we finance $330 billion? Existing public funds. Right now, federal, state, and municipal financing covers about 70% of all health care expenditures in California. Existing federal law requires that the federal government continue providing this current level of spending if a state organizes its own health care system differently than the prevailing system, as long as the state-run system provides its residents with at least the same quality of care as the prevailing system. This is the federal law passed under the Affordable Care Act, Section 1332, which provides waivers in states that develop innovative health care systems. Under this law, existing public funding will cover about $225 billion of the total $330 billion. We need an additional $105 billion. In our study, we offered two sets of proposals for getting the additional $105 billion. In the first, the state establishes a gross receipts fee or tax of 2.3% on businesses with an exemption for the first $2 million in revenues for all businesses. Through this exemption, about 80% of businesses in California, the smaller firms, would pay nothing in gross receipts fee, and medium-sized businesses would pay an effective rate of less than 1%. That would still raise $92 billion. The state could also institute a sales fee or tax increase of 2.3%. This would exempt housing, utilities, food purchase for home, and a range of services, and we include a tax credit for low-income families at 2%. That would raise the additional $14 billion. Other options are, of course, possible, and we have explored one of these in detail in our study. That is to substitute a payroll fee or tax for the gross receipts measure. For the payroll fee to generate the same $92 billion, the tax rate would have to be 6.6% on all businesses. Now, what if we wanted to exempt small businesses again? Can be done. You exempt the first $200,000 in payroll for all businesses. Again, about 80% of all businesses in California would pay no payroll tax or fee. To make up for the lost revenue, the rate would have to rise to a maximum of 7.8% for the 20% of larger businesses. What if we lowered the exemption threshold to $100,000 as opposed to $200,000? The average small business would now pay a fee or tax at 2%, while large businesses would pay up to 7.2%. Our approach in proposing these various tax measures is based on the standard goal with taxation policy to have rates set low enough as to minimize distortions. And here I want to highlight an area where I agree fully with the Legislative Analyst's Office, because they highlight this exact point on page 17. Economists tend to prefer taxes with broad bases and low rates because they minimize economic distortions. That is, when individuals and firms make less efficient decisions than they would have made without the tax. So we have deliberately designed this such that the tax rates are kept relatively low. We generate the necessary revenue at low rates. That's critical. Now, what about the impact on households and businesses? Relative to their current health care costs, most Californian families will end up spending less, even with the new taxes, and some will enjoy large gains. Working with the gross receipts sales tax scenario, most health care spending for middle-income families would fall by between 2.6% and 9% of income. Most businesses would also see a drop in spending. Small firms that have been providing health insurance for their workers will see costs fall as a windfall by 22% as a share of payroll. For medium-sized firms, costs will fall by an average of between 6.8 and 13.4% as a share of payroll. Even most large firms will see costs fall by an average of between 0.6 and 5%. This proposal is thus especially favorable for medium-sized businesses and middle-class households relative to the existing system. They will benefit in financial terms. Our results are fully consistent with the more detailed analysis that I want to cite by Professor Jim Kahn at UC San Francisco and colleagues who've developed what they call healthcare cost calculator. We can go through some details of that, but what they do is get more precise breakdowns of different family types facing different kinds of healthcare costs. Our overarching conclusion is that healthy California is capable of generating substantial savings for families at most income levels and businesses of most sizes. This will be true through a range of alternative financing approaches, including using a payroll or gross receipts fee or tax as the primary source of funding. These savings are in addition to the benefits, the fundamental benefits of the measure, which is that the residents of California will have access, all residents will have access to decent health care. Thank you.
Next, we will have Dale Fountain, Chairperson and CEO of Enact Universal Healthcare for California. And if I may, just extend my apologies to Dr. Pollin for getting the school wrong.
Good morning, Assembly members. I'm Dale Fountain, Chairperson and CEO of Enact Universal Healthcare for California. Thanks for having me here to talk about the California Healthcare Roadblock Removal Act and why a constitutional amendment is needed to allow healthcare funding. The audience for this presentation isn't just the entire legislature, but the general public. The legislature is intimately familiar with Prop 4 and Prop 98 in all their budget calculations each year, while the general public has all but completely forgotten. My presentation will build on the testimony given to the same committee on Monday, February 5th. So please go ahead and pause this video if you're watching at home, watch that one and come back. So a little about what we're doing. Enact Universal Healthcare for California is sponsoring a ballot proposition for 2018, the California Healthcare Roadblock Removal Act, or SHRA, as I like to call it. It will not by itself implement universal health care, but it will enable any future health care legislation in the state without having to go to the ballot each time. Here's an example of how our Constitution would apply not only to universal health care or incremental legislation, but to any cost controls such as global budgeting or a statewide buying pool for pharma. Total health care spending in California is $400 billion. And if the state simply held that and paid it back out, $200 billion would automatically be sent to education via Prop 98. Prop 4 would rebate $188 billion from the other half back to the taxpayers. Healthcare would be left with almost nothing. SHRA costs nothing in itself and is specifically written that way. Even the Legislative Analyst's Office found it will have no direct fiscal impact. If passed, the legislature can then pass an entire healthcare system, or it can do it incrementally. Having to go to the ballot will no longer be an excuse for inaction. SHRA exempts healthcare funding for Prop 98, the minimum funding guarantee for education, and Prop 4, state spending cap, aka the GAN limit, but otherwise leaves these restrictions intact. All right, so let's get into a little history. The picture on the left is Howard Jarvis and Governor Jerry Brown. The picture on the right is Paul Gann. In the 1970s, California homeowners were seeing their property values soar, right along with their property taxes. Some were getting taxed out of their own homes. Californians were begging the legislature for relief. In 1977, there were a few proposals bounced around the legislature, but nothing passed. Howard Jarvis and Paul Gann came up with their own plan and got it on the ballot as Proposition 13. If the legislature in 1978 had simply passed anything to lower property taxes, Prop 13 would not have gotten momentum. All hell broke loose when people found out their property taxes were increasing that year, some by 100% or more. Prop 13 passed in a landslide. Initially, Governor Brown was opposed to Prop 13. Then it passed. At that point, he became, in his own words, a born-again tax cutter. In 1979, Governor Brown teamed up with Jarvis and Gann to put a spending cap on the ballot, which became known as Proposition 4, aka the Gann limit. The fallout from Prop 13 was immediate. The school districts lost $5 billion in tax revenue, which the state depleted its own reserve to backfill. But with the state taking a gut punch with Prop 4, taxes could not be raised with other methods. In the 1980s, many schools closed, consolidated, and cut programs. Infrastructure projects such as freeways were put on hold or canceled entirely. In fact, in the district I grew up in, the city of Glendale, Assemblymember Friedman's district, she should remember this, Clark Junior High closed, and the 2 freeway project is left unfinished to this very day. In 1987, due to Prop 4, and despite the ongoing funding crisis, a $1 billion surplus was rebated to the taxpayers. It didn't take long for the CTA to put Prop 98, the Education Funding Guarantee, onto the ballot. The point being, had the legislature listened to the people who were crying out for relief, none of this would have happened. All right. For those who don't know what the Gann limit is, here's a simple diagram. Please don't stare at it too long. According to the LAO, we have about $12 billion in room as of last month. Here's one of the figures from the Prop 98 handout that the LAO gives to new legislators. Minimum funding is based on a formula that can go no lower than 39% of the budget. Right now, we're around 50%. Current K through 14 funding totals $75 billion. As you can see, it's not unusual for Prop 4 and Prop 98 to be overridden by the voters for exemptions. We had 2 on the ballot in 2016 that passed. If you notice there, so Prop 98, Prop 111 was the transportation funding, which was actually in disguise, it was actually a modification to the Gann limit and Prop 98. Prop 10 is Children's First 5. Prop 1A is the local taxes go to local authorities. Prop 52 is, which was just in 2016, that passed by 70%, and that was the hospital tax, and that was another exemption. Prop 56 is another tobacco tax. All right, popular counter-arguments to the ballot measure that I've encountered. Other than the people who deny Prop 4 and Prop 98 exist, here are the popular arguments. We can just ignore Gann and Prop 98. And, well, good luck with the lawsuit by Howard Jarvis Taxpayers Foundation and the CTA. Governor Brown himself last year, he tried to say, hey, we can just do something with nowhere money. And he backed down when Howard Jarvis was going to sue. And in fact, it's kind of weird when you're the one who put it on the ballot and you are going to ignore it. So the next one is just put Gann and Prop 98 exclusions into a legislative bill. It is weird to hear people not understanding civics. It needs to either be a ballot proposition or with petitions, signatures collected and then go on the ballot, or a 2/3 majority through the legislature and then go on the ballot. Each time it has to go to the people. The next one is a little bit in there, a little bit more wonky. Its premiums are like Snickers bars or user fees. User fees must provide a tangible service, such as bridge toll or vehicle license fee, driver's license, etc. An insurance premium is not a user fee. In fact, you can pay into insurance all you want and never get anything back from it. How does that even work? I even ran this by a judge friend of mine, and he just laughed at it. He said he wouldn't believe that somebody would actually bring that up to him. So to further distinction, part of it is intent of the Constitution itself. Article 13B, which is the GAN limit, in Section 8A, explicitly exempts disability premiums. That's another health insurance on there. Okay, so this is a wall of text, and I apologize. This is from Ben Javerser, who wrote an article on this just this last month, how the GAN limit interacts with cap and trade. It was featured in Skoka blog. It's a very good question because cap and trade is not subject to the GAN limit. And the only reason it's not, or the short answer that all this alludes to, is that cap and trade is an auction. It's not mandatory that you participate in the auction and is therefore not a tax. If you were going to claim something like, well, the state is selling something, that is also excluded. Like a state asset is also excluded in calculations for the GAN limit. I wouldn't consider insurance as a state asset, and I doubt anyone here wants to run a healthcare system as an auction. Okay. So Dr. Graves, he was here Monday. That's why I asked people to tune into that. He also wrote an article in the California Budget and Policy Center last year in July, and this is basically his conclusion. In short, rather than trying to devise a clever and likely counterproductive way to avoid going to the ballot, single-payer advocates would be well advised to ask California voters to remove the key constitutional obstacles to the implementation of a single-payer system. He goes into a lot more details. The GAN limit can't be gotten around. There are instances where Prop 98 had been ignored, but is for small increases, like small increases to a local sales tax. But nothing as huge as, say, $105 billion in taxes that we would need to do in order to, say, for SB 562. Even though that's not on top of anything, that's just a shift in revenues, that's still something that the state says is proceeds of taxes. So we wouldn't be able to do anything about that. So that pretty much ends my presentation.
Thank you very much. Next, I have Dr. Tarzynski to present from the California Physicians Alliance. Next, we have Dr. Tarzynski from the California Physicians Alliance.
Thank you. I've been accused of many things in my life, but never self-promotion, but I'm going to promote myself right now. I'm actually the president, not the vice president, as it says on your agenda. So, I'd like to thank the Select Committee for inviting California Physicians Alliance, or CAPA, to present testimony and to assist the committee in its work. My name is Stephen Tarzynski, and I am the president of California Physicians Alliance. The lead article in the January 25th issue of the New England Journal of Medicine, which addressed physician burnout, stated that there are 4 ethical principles that guide physicians in their work: a commitment to our patients, to benefiting our patients, avoiding harm to them, respecting patient autonomy, and striving for healthcare justice in healthcare. The article noted it is these values that affirm the moral foundation and deep meaning underlying physicians' view of our profession and as a worthy and a gratifying calling. It is the fourth value, striving for justice in healthcare, that I will focus my remarks today. Let me begin by telling you who we are, California Physicians Alliance. CAPA was founded in 1987 as a physician organization dedicated to advancing healthcare reform with the goal of establishing a single-payer system. We saw single-payer as the best option because it offered security, choice, and simplicity as a publicly financed nonprofit insurance and maintained our mainly private healthcare system. In our current era, it also offers cost containment without compromising access to quality care. CAPA works to develop a healthcare system, both in our state and our nation, that embodies CAPA's 5 core values. And slide, please. Oh, I have it. Sorry. I'm used to someone else doing it for me.
Yeah, nurses usually.
Exactly. Yeah, and thank you. Good, good one. Okay, all right. Yeah. These values, the 5 core values: guaranteed, universal, comprehensive, high quality, and affordable. These values are based on our belief that healthcare is a human right. Our mission is to educate and advocate for a healthcare system that is grounded in CAPA's 5 core values. We are an organization of over 7,000 members and supporters, mostly physicians, but also health professionals, other health professionals, public health scholars, policy experts, and other California residents. We also have a student affiliate, the California Health Professional Student Alliance, CAPSA, which has several thousand members and many young activists. Our members and our board continue to devote thousands of volunteer hours to the work of the organization, and our staff helps guide and coordinate this work. We also acknowledge the vital support of the Wellness Foundation, the California Healthcare Foundation, and the California Endowment. CAPA has a 3-pronged approach. We work to help people get coverage now. We work on medium-term health reforms that are consistent with our values, and we work to advance to a system that will embody those 5 values. One example of our work to improve the lives of people now is our student program called Project Whitecoat, which to date has enrolled over 500 families into covered California and Medi-Cal. Over the years, CAPA has worked on a variety of incremental state legislation to expand coverage and benefits for various groups of Californians. Some of the legislation CAPA has supported included SB 810, the single-payer bill authored by then-State Senator Sheila Kuehl, that passed the state legislature twice and was vetoed twice by then-Governor Schwarzenegger. AB 72, which allows consumers to only be responsible for their in-network costs, preventing unanticipated bills from medical providers and services that they didn't choose or over which they did not have control. And the one that CAPA is most proud of, since we worked hard with others to get this passed, SB 75, Health for All Kids, which expanded Medi-Cal coverage to all children in California, regardless of immigration status. CAPA currently supports the passage of a number of other bills currently in the legislative process that would further expand coverage and protect patients. CAPA supports the Affordable Care Act, which was an important and historic step forward in the struggle to achieve health care for all. I stated that CAPA played an important role in including the state's undocumented children in the Medi-Cal system. We also worked to successfully pass state legislation for a federal waiver that would have permitted undocumented adults to purchase health insurance at their own expense in covered California. Given the virulent anti-immigration position of the current administration in Washington, the state withdrew its request for a waiver. And although this waiver request was a very small step, it did establish the principle that undocumented adults should be included in the state's healthcare system, and this in and of itself was an important policy milestone. As for my personal history, very briefly, I am a board-certified general pediatrician and fellow of the American Academy of Pediatrics. I graduated from Rush Medical College and did my internship and residency in pediatrics at Los Angeles County USC Medical Center. On January 1st, I retired after 40 years of full-time practice, which has also included international work, teaching, and medical group leadership. The last 33 years spent as a practicing physician and partner in the Southern California Permanente Medical Group, providing medical care to the members of the Kaiser Permanente Medical Care Program. I will continue working part-time as a per diem physician in that organization. I do want to be clear that my remarks here today are my own as a private citizen and CAPA president and do not represent the position of Kaiser Permanente. Yet. Yeah. I'm talking to them. For the past 45 years, that is almost my whole adult life, I've been deeply engaged in advocacy, policy development, grassroots organizing, and organizational leadership to advance healthcare reform and to achieve a single-payer system in our country. Why has the United States lagged other wealthy nations and failed to achieve true universal coverage? It certainly has not been for a lack of trying. Rather, the reason lies in the struggle over the role of government in medical care that has been going on since the very founding of our republic. The effort to increase the government role in medical care has always been contentious and fraught. From 1798, when President John Adams signed an act for the relief of sick and disabled seamen, through the 19th century we saw great advances in public health, to the 20th century with the failure to pass the Shepard-Towner Act, to the successful effort to pass Medicare and Medicaid, and to the recent effort to pass and now protect the ACA. Some people have never accepted the idea that government should use its power to improve citizens' physical well-being. This opposition to government-regulated medical care is partially based on the view that government governs best which governs least. Liberty means an uncontrolled free market and the individual pursuit of self-interest. Human existence itself is viewed as a zero-sum game where there can only be winners and losers. Today we hear calls to bring back policy from 17th century England's Elizabethan Poor Laws, when there is talk about low-income, able-bodied adults needing to work to deserve health insurance. We have seen this in the past few months, repeated attempts to gut all Medicaid funding to the states give them the option to place a work requirement before so-called able-bodied adults can deserve health insurance. Several states are actively considering and moving towards such measures. No other civilized nation makes such a demand on its people. From my decades of experience as a doctor, it seems to me that no market-driven healthcare system can simultaneously limit costs, guarantee universal coverage, and deliver desired outcomes. Overwhelming evidence demonstrates that the best ways to reduce costs and guarantee healthcare to everyone is to have the largest risk pool, that is, the entire nation. These facts compel the United States of America to move to a single-payer system guided by comparisons with other countries' experiences and by our own American successes, such as Medicare and Medicaid. However, given the current contours of the political terrain in Washington, the current congressional alignment of forces, and the current occupant of the White House, it's rather unlikely for the moment that we can make the entire nation the risk pool. We instead need to look to the next largest risk pool, which would be a very large state with elected leadership that has committed itself to not being afraid of using government to advance the universal coverage. A state that has an economy the size of France, that has a population larger than Canada, and is the world's 6th largest economy. That state, as we all know, is our state, California. CAPA, along with many others, including those who are testifying and in attendance here today, believe that California can and must take the lead. This belief is grounded in the history of the Golden State as a leader in social progress, arts and culture, business, technology, public infrastructure, education, and other innovation. With respect to universal coverage is a term that is used by everyone. Universal coverage is like mom and apple pie. Who could possibly be against it? But this term is also used by interests with varying motives. Some behave as entrenched interests who profit from the current system and see an opportunity to further increase their margins in their version of universal coverage. But universal coverage is not enough. CAPA's goal is indeed covering everyone living in California, but in a healthcare system that is affordable, not wasteful, of high quality, and socially just and equitable. No one should go bankrupt because of medical bills or go without needed care because it is unaffordable. Everybody in, nobody out. That is a California value. In California, we have taken bold steps toward universal coverage using the opening created by the ACA to bring as many individuals into our system as possible. Our state leaders and many others have worked to make covered California marketplaces as effective and inclusive as possible, even defying the current national administration in its attempts to gut the annual enrollment process. Medicaid or Medi-Cal expansion in California has achieved impressive results, including, as I noted above, the important step of protecting all undocumented children. Yet despite all this outstanding and historic work, the goal of universal coverage, framed by CAPA's 5 core values, continues to elude us all. It is to achieve this goal now that I wish to turn my remarks. CAPA's perspective is that as long as coverage is tied to employment, inherently wasteful for-profit insurance companies are in the system, and prices are not effectively controlled, we will never achieve health care reform grounded on our 5 core values. CAPA's approach is also framed by the reality of what California can and cannot do in the current period, and that certainly begs the question of the feasibility of some type of single-payer system. Any state-level approach to some type of a single-payer system requires capture of federal funding from Medicare and other programs. This capture, in turn, requires new federal waiver legislation. Yet in the current political reality, unfortunately, we cannot expect these waivers for at least 3 years, and that is if we are very lucky. Workable majorities in the House and Senate willing to approve and a president willing to sign such waivers must exist. So that gives California, at minimum, a 3-year period in which to prepare to transition to some type of single-payer system. CAPA believes that one way forward may be a step-by-step process that builds the broadest consensus possible among all stakeholders, and that also ensures that we will not get stuck in the transition phase and fail to achieve our goal. CAPA realizes that it alone cannot develop a detailed policy proposal that can be translated into legislation that will be required to achieve such a major transition. Yet what we can do is bring together the expertise that will develop that policy proposal. So CAPA has launched what we call our Roadmap to Single Payer in California. The roadmap process, through a series of statewide meetings and working groups, has been bringing together over 100 experts across a variety of disciplines, including practicing physicians, nurses, other allied health professionals, health policy experts, health economists, public health scholars, experts in tech, experts in healthcare systems engineering and quality improvement, legislators, organized labor, leading healthcare reform activists, and others to work together to develop a realistic pathway to single payer. The goal of CAPA's roadmap meetings is to develop a document by late spring this year that will serve as a template for legislation to achieve the goal of universal coverage in our state based on our 5 core values. 2 very successful statewide meetings have so far been held in Los Angeles and in Sacramento, and Dr. Wood was at the second one. The roadmap process continues. At the same time, CAPA realizes that in crafting legislation for a better state healthcare system, it is essential, and that committee, at the same time, CAPA realizes that in crafting legislation for a better state healthcare system is essential, and that the committee has invited CAPA here to address this. We are aware from meetings with select committee members there are specific concerns with respect to lack of coverage and services in rural areas and that of the devastating impact of the opioid epidemic. We share that as well. Our roadmap process is ongoing, and it has so far identified a few broad policy areas that will need to be addressed in a major transition, and these areas are listed on the next slide. Yeah, sorry. Shame on me. Okay. All right. We can certainly, some of the areas, as you can see, are savings and revenue, affordability, delivery system reform, workforce, coverage, insure the uninsured, and benefit package, price control, governance, health information technology, Medi-Cal improvement, public option, and there will be others. We can certainly go into a little bit more detail in the question session. CAPA envisions calling our improved new state healthcare system Golden State Care, and I credit former director of Los Angeles County Health Services, Dr. Mitchell Katz, for suggesting the name. Golden State Care would be rolled out in 2 phases. Phase 1 would occur over the 3 to 4 years, while we also work hard to create the conditions for federal waivers that will lead to the establishment of a statewide all-payer system. That is feasible at the state level without federal waivers or permission. The committee has already received testimony on countries with all-payer systems and in other wealthy nations, as well as 4 states that have tried to do this. Phase 2 would then move to some type of single-payer system once the required changes at the federal level would occur. As the committee has already heard, there are many types of so-called single-payer systems around the world that have achieved universal coverage. California and the nation can learn from these examples, but ultimately, we must develop our own system. We believe that phasing in significant changes in financing and delivery of care would help mitigate the massive disruptions and dislocations and blowback that could otherwise occur from too sudden and overnight change. Such a time frame could help minimize the risk aversion or fear of millions of Californians who, satisfied with their current coverage, would be afraid to lose it in an overnight process. Opponents of single payer will certainly exploit this fear. Moreover, public financing will be essential in this process, and Californians have shown that they are unusually generous in taxing themselves, yet there is still a question of how far taxpayers are willing to go. Basically, reformers still face the challenge of the public's negative perception of taxes and government. The roadmap process is already addressing this challenge. It is key to understand that any new taxes would actually substitute for the cost of current insurance premiums. It will likely be lower than those premiums and thus a better deal for the average California taxpayer. Before leaving the issue of financing and affordability, I would like to emphasize one important point from the working clinician's point of view. We know that paying doctors is about 23% of all health costs. If physician reimbursement were cut by 20%, it would result in less than a 5% decrease in overall health costs, but it would very deeply impact a profession already saddled with twice the burnout rate, now reaching 54%, of other professions, and a higher rate of substance abuse, depression, and suicide. An attempt to cut costs in this manner would make the people who care for everyone in this room even further demoralized than they already are while dealing every day with time-wasting paperwork and documentation that takes away from caring for patients, which is all they really signed up for. Conversely, increasing physician reimbursement in Medi-Cal by 20% or even just in Medicare rates might only increase healthcare costs by less than 5%, but vastly open access to primary care and specialty care and result in eventual decreases in overall health costs, especially in the context of universal coverage. Similar burnout rates exist within the nursing profession. Let's not continue to try to solve the problem of affordable health care on the backs of our physicians and our nurses. This has been going on far too long. I would briefly like to comment a bit further about the current single-payer bill, SB 562. Let me first be very clear that CAPA is in solidarity with the goal of SB 562, a system that would embody CAPA's 5 core values. So SB 562 supporters are to be commended for the vital role they are playing in building support for single-payer and educating the public about it, and for moving the California Senate and Assembly forward in their consideration of the concept. The backers have also played an important catalyst role. CAPA respects the advocates and supporters of SB 562. At the same time, we fear that the bill itself has language that, if not substantially amended, will prevent its passage. The concerns about the bill's language have been elaborated by others, and I will not repeat them here. CAPA hopes that SB 562 can be amended to present a more realistic transition along the lines I have laid out. We are very willing to work with the bill's authors and its key supporters to that end. And most importantly, CAPA strongly believes that all stakeholders should come together in a useful, constructive, and truly collaborative process based on CAPA's 5 core values. Some have criticized our approach as incrementalism, but we in CAPA call it strategic planning. There are 3 take-home points to remember. First, a strategic transition in 2 phases is necessary, and it must engage all key stakeholders. The starting point for this process should be agreement on the goal of healthcare system based on our 5 core values. Second, new federal waiver legislation is needed. And third, the work of developing this phased strategic transition plan is being done by CAPA and others in the roadmap process. The last slide, please. That's 4. Okay. Yeah. I'm really talking to myself. There we go. That's right. That's what happens. You have AV people for 33 years. So. I've tried to outline values, a vision based on those values, a strategy, a process, and a goal. In closing, let me just leave everyone with some numbers. We know that Medicare, the closest thing we have to single-payer system in this country, and which enjoys widespread support, has an overhead of about 2%, while private for-profit insurance can range anywhere, depending on the study, from 10% to 25%. In other words, government is more efficient at paying for medical care in a predominantly private-run healthcare delivery system by a factor of 5 to 12 times than the private for-profit insurance industry. Government doesn't have to pay investors, pay executive stock options, build huge skyscrapers, or figure out how to not pay for needed medical care to maximize shareholder value. And from several studies, we know that for each 1 million uninsured, 1,000 people will die a premature death every year due to lack of insurance. In Canada, the United Kingdom, France, Australia, Japan, Germany, and other wealthy nations, that number is 0. Thanks to the ACA and expansions in Medicaid and Medi-Cal, tens of thousands of lives have been saved. But the job isn't finished. Right now, almost 3,000 Californians are still dying every year just because they don't have health insurance. That's 8 people a day, 1 every 3 hours. How many more must die before we achieve a California healthcare system that is universal, guaranteed, comprehensive, high quality, and affordable? Getting to 0 is up to all of us. Thank you for inviting us to present testimony to the Select Committee. We view the charge and work of this Select Committee as serious and meaningful, and we are ready and willing to continue to assist you in your efforts. If there's time, I will ask my colleague and CAPA board member, Dr. Arthur Chen, to make some brief remarks. He's much smarter than me. He can answer all the questions.
But I also failed in my role as his slide changer. Good afternoon, and thank you. And I will be very brief because the main point of my being here is to assist with any questions that you might have. My name is Dr. Arthur Chen. I am a practicing family physician for the last 34 years at Asian Health Services in Oakland, California, which is a federally qualified health center that is in the safety net for Alameda County. I've also had the privilege of working on single payer for the last 25 years, since the original campaign for Prop 186 started in California. I have also had the privilege of being a public health officer for Alameda County in public health, and also a chief medical officer for a Medi-Cal managed care plan, which is the Alameda Alliance for Health, back in its earlier days. I've had an additional privilege and vantage point of being the board chair for the California Endowment, a healthcare foundation that you're very familiar with that has supported many of the progressive changes that we're trying to see in improving the health of our communities. It's with these different vantage points that has informed me about our healthcare crisis that we're in and how we're approaching it, and some of the solutions that are out there that are not theoretical but are actually very practical models that have amazing track records, as has been mentioned by our previous speakers, that are actually achieving universal health care and that are actually doing it in a very cost-effective way and are doing it in a way that improves quality and generates outcomes. And I'm just taking one step back and listening to the testimony today and thinking of where we are. And I can't help but thank you, specifically Chairman Wood and also Chairman Arambula, for delving this deeply into this issue. It truly is historic, and it was long overdue. And I want to thank the California Nurses Association as well as Single Payer Now, Healthcare for All, a number of these very dedicated and passionate people who care so deeply about the health status of our communities that they are willing to put in their time and show their passion. And you know what I mean when I say show their passion. And hopefully, all of you can take that not on a personal attack level, but take it as a sign of how bad things have gotten and how they are taking and we are taking ownership for this problem. We're taking ownership in the only way that we can as private citizens and organizations by expressing public will, even though it may be in a very forthright way that may have some abrasive edges to it. It's because of that concern that you have as well, and that you're taking ownership of this, and the fact that we're doing it together right now. I think from my vantage point of being a healthcare physician for the last 35 years is just incredible. And I want to just thank everybody for that contribution. I look at SB 562, and I went through it again last night. I had presented it to the North California Neurologic Society, and I took a lot of heat among physicians groups because there's a lot of concern and there's a lot of fear. But I want to say also that when I look at this from the context of a public health perspective, of a practicing family physician, as someone who's really concerned, as you all are, we have some incredible elements in this proposal that should always be part of a piece of legislation, no matter what you decide to do in trying to advance universal care. I want to point out that this avoids the separation of eyes and mouth and head from our body, that it integrates care, that it puts vision care and it puts, oral care all under the health coverage. How complex an idea is that we have gotten to the point where we're so fragmented we don't address that. So thank you for putting that in the proposal. Seniors and disability. For those of you that haven't read this, it provides for adult day care and in-home care where it's critically needed. Anyone who has been taking care of an aging parent or is going through this yourself, as a senior, this is critical and very much a part of quality of care and enabling quality of care. And I could go on, but in a period where we are dealing with immigration as a big issue, this is immigrant friendly. This is very immigrant friendly. There are provisions in here that actually are in sync with our sanctuary state laws that actually keep information on immigration status private and not disclosable to anyone who's looking for that information. And so there's a lot of thought that went into this. There's also its cultural competence, and they also talk about from a minority health standpoint and some of the biggest challenges we see within our minority communities around health disparities. They openly declare that we need to seek the elimination of health disparities and provide care and address cultural and linguistic barriers. So in summary, I just want to suggest that get past all the issues that are coming at you from a public will standpoint. And please don't ignore the content of this bill, the value that's there. Try to amend it as our position in CAPA is we support SB 562 if amended to address some of the points that Dr. Tarzynski brought up. And we stand with them in solidarity in trying to accomplish that because we think the motivations are very real and very sincere and absolutely necessary at this point in time. Thank you very much.
Thank you all for your testimony. With that, we will bring it back up to the dais for any questions that the committee may have. Assemblymember Friedman.
Thank you. Thanks for all of you for coming today, especially from Massachusetts. We have better weather, so maybe that's a draw. Gosh, I have lots of questions. I'm not even sure where to start. I don't know if you've all had the chance to watch the other presentations that we got. And let me also say, I came into this as a healthcare user, but not a healthcare expert. I'm not a physician. I don't play one on TV. And so this has been a real education to me, a real deep dive. And I know that it's frustrating to a lot of the advocates who know a lot about healthcare that we all have gone through this. But for those of us who have to make policy, it's really important that we understand the background and all of the dimensions of this. And even though we sat through many, many hours of hearings, they were so dense that for me, I would need to, probably take a course for many years to really be able to absorb all of the information that we've been given through the course of all the hearings, but I'm starting to get, much more of an understanding. So I have some questions first for Professor Pollin, and again, thanks again for coming. So my first question is about the fee on businesses that you mentioned that you did your analysis on. I think it was you talked about a couple of different proposals that you looked at to come up with your assumptions about the amount of money that's available that's being spent now. And the fee that you recommended in your analysis to come up with the cost, of how to pay for the cost of the plan, I think was around a 2% payroll tax, gross receipts tax. But do you have a sense right now of companies that are paying for private health insurance? They're paying much more of that right now than 2%. So, one of the speakers that we had was a governor of Vermont, who said that one of the mistakes they made when they tried to propose single payer in Vermont was not clearly explaining to the public what they're paying now. So those companies are paying much more. What was your sort of general assumption of what the average company that provides private insurance is paying?
Thank you very much for the question. So first of all, as I said in my overall remarks, a very important consideration in the way we designed our proposal was precisely to remain within the framework as articulated in the Legislative Analyst's Office, which is to prefer taxes with broad bases and low
Right.
rates. And the mistake that was made in Vermont was that they didn't do that. They could have done that. They didn't. As it happens, I've had extensive conversations with the author of the study for Vermont, who, in my opinion, is the most eminent economist working on single-payer health care and related issues in the world, Dr. William Shao of Harvard University. He himself told me that they made that mistake. They did not adhere to this principle, so that the proposal was for a very high rate that got people worried. Now, so exactly what we were really focused on was designing a system through which the rates, obviously we have to raise the money, but the rates are not so high as that they would cause distortions in economic activity. So, so in our study we have, if we take it as an example, medium-sized businesses, and we looked at two kinds of medium-sized businesses with 10 to 19 employees or with 20 to 99 employees. So right now, the 10 to 9 employees are spending $108,000 on health care per year, and what they would pay through the gross receipts tax scenario would be $25,000. So the gross receipts tax proposal would lower their health care spending by 13.4%. As I said, this is a major benefit for medium-sized firms. That's not quite as big for 20 to 99 employees, but in that case, right now we're showing total health care spending is $315,840. The gross receipts tax, they'd pay $184,000. So they would lower their health care spending as a share of payroll by 6.8%. So consistently, except in some cases for certain kinds of very large firms, the health care costs for businesses go down. And, you know, the gross receipts tax is one example. I know there's some concern, and I read the legislative analyst's office concern about the gross receipts tax. That's fair. Of course, you're going to be concerned about any fee or tax. On the other hand, very large states operate with these. This is not a big secret proposal. We have Texas, we have the state of Washington, we have the state of Delaware, we have the state of Ohio that depend heavily on utilizing this measure. So we can do it. On the other hand, if you wanted to go with extending the existing payroll tax, it's certainly doable. As I said, it would be 6.6% to raise the same amount of revenue as you would get from our 2.3% gross receipts fee. So you can do it. And, you know, 6.6% is higher than 2.3%, but it is still within range of something that would not be onerous, as was the measure in Vermont, which was, it's unfortunate in Vermont because otherwise the research done, the proposal, in my opinion, was outstanding. The work done by Professor Shao, outstanding. In many ways, I modeled our study on his. They had that one issue that you've highlighted, which I think they could have done a lot better.
Now, you used the phrase several times. You said decent insurance. So what assumptions were you using in your analysis about the type of insurance that this would pay for? Because there's a big range of insurance that's offered by, you know, from private insurance, for instance, who some companies are giving platinum plans to their employees, you know, all the way to people in covered California buying, you know, a higher deductible type policies, to what's in 562, which, you know, seems to be written as is much more like along the platinum, if not higher, type of analysis. So did you envision any particular cost for a type of insurance, or are you sort of spreading the range and finding an average and using that as sort of your cost assumption? Or does that matter when you do an economic analysis like that?
Well, of course, all these things matter. And of course, when you do a study of such a big system we have to work with averages, and we think about ranges within averages. So, the basic approach was to say, let's look at existing coverage. And within the existing coverage, we find about 45% of people either uninsured or underinsured. And again, if you want, I can go through other definitions of underinsured, because I think it's very, very important that we understand how severe that problem is. And then what we said was, let's bring everybody who is either uninsured or underinsured up to fully insured, such that they do not face these kinds of problems, that they feel like they can't see a physician, or that they face bankruptcy. So bring everybody up to that level, and that what we said to do that would entail costs going up by about 10% within the existing system, so from $370 billion to $400 billion within the existing system, but then that the single payer system would achieve cost savings such that we then get everybody at decent coverage at $330 billion. So it would be a net reduction in costs in the range of 8 or 9% with everybody getting.
Right, but are you anticipating the type of coverage that the bill calls for, podiatry, long-term care?
Yeah,
all of that was also in there. Okay, good to know.
Yeah.
And then were you also anticipating additional types of cost savings? Being more regulation, I mean, clearly you're taking out the for-profit insurance industry, siphoning off of money going to shareholders, correct in your assumptions?
Yeah.
And also the ability of the state then to negotiate directly or regulate with pharma, all of that. So that's where, so you have cost containment built into your modeling as well.
Yeah, that's right.
Okay. Good. Trying to think. And then did you also make assumptions then about a flattening of did you make assumptions about fee for service versus more, I don't know what the phrase is for when you're just doing a flat sort of contracting with with doctors?
Well,
sort of managed care system?
in my reading of the measure, those options are still on the table, and in my opinion, what we need is some combination. And if I turn to our study, we actually quote from the bill itself. So the bill itself talks about simplification, transparency, standards shall include but not be limited to fairness in healthcare credentialing, participation, healthcare referrals. So in my view, the language in the draft legislation broadly mandates the board to develop single payer as an integrated system. Now, what exactly do we mean by an integrated system? And there are various ways to do that, some of which could include fee for service in some contexts within a broader framework of some kind of global budgeting. So that's what I think. That's I think where we will evolve. And we have pieces of that already in operation in different parts of the country. For example, in the state of Maryland, they have global budgeting. They are evolving it in a positive way, but it has to be done within a context which it's not entirely done now, in which we guarantee decent care. So that is a level of detail that, in my view, is not fully worked out in the bill thus far, and shouldn't be, because it is a matter of a lot of study and detail and understanding a lot of the models that are out there and making them work in the most effective way.
And then have you evaluated single-payer systems versus a very highly regulated nonprofit multi-payer system like they have in Germany and some of the other countries? Do you have any thoughts about that?
Well, I think that in the United States, we've evolved into a system in which we are heavily dependent on the private health insurance companies, that they have enormous market power. And that is a major factor holding back the creation of a universal coverage system. And that therefore, what is really most critical, in my view, is the transition into a simple system, a government-run system. And we have experiences with, for example, Medicare, which has a lot of favorable outcomes, but is enormously costly. We don't have any kind of cost controls within it. A lot of the reason is because of the interaction between the providers, the insurance companies, and the state. So I think in order to achieve a system that accomplishes the cost savings that we need, I don't think we can run our system like Germany's. I think we need to move to a simple system with minimum bureaucracy and minimum ambiguity.
And lastly, is there any credible economist that you know of who thinks that our current system, our unregulated current system, where insurance companies, where we have such a lack of regulation and force citizens to buy from competing insurance policies with very little care about whether or not they actually can afford what they're able to get. Is there any economist who thinks that this is working?
I think that's a loaded question.
You can just say no if you want.
No.
Okay. Thank you.
Next, we will have Assemblymember Waldron.
Thank you, Mr. Chair. There's a lot here, and I know everyone wants to get to the best solution for the patient. I'm always concerned about access for the patient, and I've run up against issues with appropriations, trying to get better outcomes through eliminating step therapies, getting physicians to actually be able to get the treatment they want to their patients without all the red tape. So I'm very interested in it. I'm going to play a little bit of a devil's advocate here because, we're at the end of the rope, I think, as far as a lot of our informational hearings. And I think some of these questions need to be asked, and I'm asking them because I really want to know. It's not, anything other than that. One of the things we run up against as legislators when we try to run bills in appropriations, we try to set up a program or a system, and there's always those initial one-time costs that come into play before we actually then, get into the nitty-gritty of what the outcome will be for the program. What would be the one-time costs to the state's general fund or other source of getting a single-payer system off the ground? And how will that be paid? I mean, I know we're talking about the $400 billion, pretty much static operational costs, but what do you see as a setup on this?
For me?
Or whoever.
Yeah, I'm going to defer to the economist.
Well, there definitely are transitional costs. And I think it's fair to say that our study version came out in May does not cover those. And it would be a fair criticism of our study, but it really was just a matter of doing what I could within the time frame. Subsequently, we have looked in some detail with respect to transitional costs for people now employed in the private health insurance industry. Because a lot of the ways we're going to achieve cost saving in the system through lowering administrative costs means, let's face it, people will not be needed to do their jobs in private health insurance. So what we've estimated is a fair transition to move people who are employed currently in private health insurance in California, and that's about 150,000 people, 147,000. And what it entails are, first of all, people who are near retirement, moving them into retirement, voluntary retirement, through a glide path to maintain their wages and pension funds. Secondly, the people who are not near retirement. So that is going to be about 125,000 people. We estimate that about 75,000 will still be needed to move into the public system. but that still leaves us with about 70,000 who won't. So what we have looked into is the rate at which retirements occur in public employment in the state of California, not in healthcare, but in comparable positions, and the rate at which new openings would emerge through which these people could move into. And we estimate that it would take about 3 years' worth of normal rates of retirement to get people into employment if they wanted that employment. But we've also looked at ways of positions for wage replacement for 2 years for people that don't take those jobs. We've looked at job training and relocation costs. And roughly what we're talking about is, I think, it cost an incremental increase on top of the $330 billion, an incremental increase of around 1% of system costs for 3 years to get people into a good transitional situation. So the costs are real, and we can't ignore them, but they are manageable. They're certainly manageable, and when we finish this latest version of what we're doing, we'll be able to show that.
So you had mentioned about...
Could I also respond to that?
Okay.
Just from a physician and public health standpoint, there's part of what, and I don't have all the research behind this, but it's an idea that might be studied. Part of the change that would also generate costs is shifting to an entire new system or an entire new bureaucracy, an entire new agency, and so on, to be able to carry out. We learned this somewhat from Covered California, becoming a new entity and having to staff up. So the question really for us is to figure out how much can we parlay what already exists and massively improve it. And I emphasize massively, because if we think of what infrastructure we already have, we have an infrastructure in California. It's called Medi-Cal. And it provides a lot of all the different aspects of what's needed in healthcare, and at different times has provided that comprehensive care and actually included podiatry and things like that. But it needs major, major overhaul. But it's different than having to reconstruct an entire agency. So that's one issue. And then the other thing is, in the course of transition, of course, dollars are real important, but don't forget about benefits that occur. Because in that transition, for example, I can tell you from a physician office standpoint, incredible, narrowing down and simplifying of what are very complex and rigorous and laborious and, activities that are costly as far as having staff to be able to deal with different forms and different policies and different contracts from all these different payers. So don't overlook that aspect of what we actually improve in the efficiencies and cut down on the costs of unnecessary overhead for many, many physicians' offices and medical groups.
And many physicians spend 20 hours a week on this, and it's $83,000 per U.S. physician cost. So if you've got a group practice of 4 or 20 or 50, you can think about what the costs are just through the administration and how there are savings there. And there are also, I think, savings that we could look at for streamlining and improving Medi-Cal, as Dr. Chen alluded to. And for instance, do we really need 50 eligibility codes for Medi-Cal? Seriously?
Just a couple of follow-ups on that. So the private insurance during the transition, what role do you see for them? I mean, will they be part of this, trying, maybe doing the billing, are they going to be somehow involved in the transition, or will they just be kind of on their way out?
Well, the language of SB 562, provides that the program is not fully operational until the federal monies have been received. And so there is that period of time potentially where we are transitioning in the program, and that's what Dr. Pollin's next study is going to review the specifics of, and clearly the CAPR project as well. But it is certainly possible that there will be provided private insurance during that transition period. It's also possible the insurers will, decide that they want to pack up and go home, and so we'll have to find alternative means of coverage. I think that the reality is that the coverage that folks currently get is, as we mentioned earlier, 70% publicly funded. And so we're going to have those public resources that we may be able to reallocate during that transition period as well, at least on the state level. So that's what we anticipate.
Okay. What level of reserves would be needed to cushion the impact of large cost jumps or revenue declines, which we see all the time, in any budget, and we know
Yeah,
that those
that's
happen.
that's a great question. It's another one that is not in our study, but we've worked through it, and I'll be able to send you some results on that. But let's just think about it in the basics. We've looked at, for example, the payroll tax option, which I understand people are very interested in that. The gross receipts would be, similar. So what we've looked at is the range of jumping up and down. And, for those of you that remember your statistics, the standard deviation around the average is about 4.5%, meaning so that if we've got a given amount of revenue a year, some years it'll go up by 4.5%, some years in the maximum go down by 4.5%. So the basic principle for creating a reserve fund is just quite straightforward. Once you know what the long-term average is, then what you're able to observe is, the jumps up and the jumps down. And what you have to therefore do is incorporate a provision through which when you have a good year, a jump up, you don't spend that money. You put it in the reserve fund. And that is then exactly going to be matched by the years when you go down by 4.5%. You will have the money in reserve from the up year. So it's not hard to design a reserve fund that will be viable. What would be a bit of a challenge is, for the first couple of years until you have your first up year, how do you cover that? So initially you would have to start putting in the reserve fund as an additional increment for the first year financing. But after that, it's really not a very hard problem, given, all you have to do is observe the range of variation around the long-term average amount of funding coming in.
Okay.
Can I respond also? And it somewhat relates to the previous question around the role of private insurance. This is why in the single-payer model, we really have to have it as publicly financed, and at least for a minimum benefit package, a minimum baseline, benefit package that everyone can feel covered by. And as a result of the importance of the actuarial spread, because to avoid the down years, to avoid the down swings in the revenue that comes from this, you have to have the actuarial spread of healthy working people and healthy children and so on that are still part of that tax base. And so if that's siphoned off because of having a large role of private insurers, then we lose that benefit. The role in countries that have single payer as well as other multi-payer systems, there's still a role for private insurance. And that is really, once we establish the floor at the basic minimum benefits package, if people want something more than that, there's an option to be able to go private insurance and do that. What you'll see over the next few years, because insurance companies are very keen on their profit margin, is a lot of the companies that have multiple product lines and do life insurance, for example, they're getting second guesses about staying in the market. And part of it is because the margin for them, despite the fact that it's billions of dollars, hundreds of billions of dollars, as individual companies, is starting to narrow down. And not surprising because of the crisis that we're in with our fragmentation and a lot of the challenges that we have right now in our system.
Which is why SB 562 moves expeditiously to transition from the insurance-based system to Healthy California. And I think that certainly this minimum benefit package is not a concept in SB 562. The comprehensive benefits are the package, because the bigger the role for the private insurers, the less efficient and less savings and more waste there is in the system. So that's why we've put forward a very comprehensive benefit package to reduce the role of private insurance to supplemental benefits.
Okay. I have a few more. Okay, so let's get into some of the charts. Dr. Pollin, on Table 9, you're outlining some of the overall cost savings through the California single-payer system, estimates, obviously. So you're estimating health spending will be reduced by about 5% as a result of reductions in unnecessary services, reduced fraud, other efficiencies. What is the basis for this estimate? Are there some concrete figures or studies that have been done that could point to, and that's kind of a broad thing, unnecessary services, and I totally agree with what's been said about a lot of the things with step therapies and, denials and all the costs that go into all of that, navigating a very, broad system. How did you come up with the 5%? To the extent that some care being provided today is not high-value care, why should we believe that this would change under a fully publicly financed system?
Thanks very much. That's a great question. The figures here, like all of the figures on cost savings, come from the research literature. The starting point for our estimate of the 5% is from a 2010 study by the U.S. Institute of Medicine, which is the medical branch of the National Academy of Sciences. That 2010 study estimated that waste, not total waste, but waste in these four categories: unnecessary services, insufficiently delivered services, missed prevention opportunities, and fraud, was not 5%, was 19%. Okay? 19%. Now, as we go through in our study, that was a 2010 study, and as we go through, there is more recent research that affirms that basic finding, or actually suggests that the number is too low. Now, there are people that say that, okay, that's not realistic, that yes, there's all this waste, but we don't know how to get at it. There's no way to get at it, so there's no potential savings. I've received that criticism on our report from people I respect. I disagree with that, because if you cannot get at it in any way, even under a totally reorganized administrative structure, then actually it's not waste. It's part of how the system operates. So what we suggested, the 5%, is actually a very low figure relative to the serious research literature, including the work of the person who was the head of the CMS under President Obama for some time, who has read our study and actually said your number is actually low. So we think that's a conservative estimate of the potential savings in this area, and part of what gets us the savings is through instituting some kind of global budgeting system, and then also including with that the types of commitments to care and to the board that is proposed that is going to provide oversight into these areas. So we have the cost containment, we have the system of review, and we should be able to get somewhere in the range of 5% out of the roughly 20% that the research literature says exists in the areas of waste. And by the way, this 5% figure, the study for Vermont that was referred to before, they say it's 20%. So my number is actually quite low relative to what's out there.
And it would be better to be low, because if you experience better savings, then that's all the better for the.
Yeah, sure. But what we definitely didn't want to present you all decision makers with unrealistic figures. So, our study, naturally, every study is criticized. And a lot of the criticisms have value, no doubt. Some of them don't, but okay. But the point is that when we got the main area of focus of criticisms was around this issue of cost savings. But if you look at the net, the debate that's gone on, a lot of the criticisms kind of cancel each other out. Some people say we were too low in our estimate of administrative savings. Some people say that we are too high on this 5%. The 5%, relative to the 20% that the research literature says is waste. Overall, I think our overall estimate of 18% savings is a conservative number, an attainable number, realistic.
One of the things that I always incorporated into unnecessary services was all the added on testing. You need this test, you need that test. And I think part of that is based on the concern of malpractice and lawsuits. And, it got to a point where, my brother's a physician, and he's spending a lot on malpractice, just coverage. And he's not in California, he's in New York, so they don't have the protections that we even have here. Mm-hmm. That is a big deal, I think, those lawsuits. Is that addressed in some of this unnecessary services? Because I think the result of lawsuits is extra testing.
Yes, I mean, so we discuss in the studies what is called in the literature physician-induced demand, where physicians either are suggesting excessive testing because they're fees that they can generate, or because they're afraid of lawsuits. Mm-hmm. And so when you move to a single-payer system with a simple administrative structure and clear guidelines with integrated care or global budgeting, the possibilities for these kinds of problems, it's not that they're going to go away entirely, they're going to be diminished. And that's how we get the savings.
I think there's also some opportunities for, in transitioning to another system like this, there are opportunities to change or reform or improve the delivery of care, delivery systems. And we need to look at that. We're already we're moving from volume-based payment to value-based payment, and looking at evidence basis for what types of models of care work better. Fee-for-service, very inefficient, very volume-based, non-profit integrated delivery systems. Evidence basis for that is good. So I think there are opportunities in doing this besides saving money immediately or in the long run to reform how medical care is delivered and using the evidence basis that makes it more efficient and evidence basis for appropriate care, quality reporting, all of those kinds of things, performance, access, service, quality, those kind of things.
And we believe that SB 562 does that in a better way than the kind of practices that are used now. The value of paying for value over volume has not saved money in the U.S. healthcare system. That is a mandate under the Affordable Care Act that has not yet proven its efficacy. And in fact, recent studies have shown that those models inherently discriminate against poor people and people of color. So we would object to the application that Dr. Tarzynski is speaking of. In the interim, where insurance companies are still in charge, there's no control over costs or prices. And in that environment, there's every incentive to reduce care in order to further the bottom line. The best example of that kind of system now, of course, is Kaiser Permanente. They make $1 billion every quarter. $1 billion every quarter. We don't think that's justified.
I just want to deviate really quick on just a little sidebar before I get into my next finance question. One of the things we heard in one of our previous hearings when we looked at international applications of either attempts at single payer or at least universal coverage with multiple paying systems, one of the things that helped delivery of service, actually care to the patient, which is the big deal, that they're actually getting care, was this social service network that was around them. And I'm looking at the, here we have the comprehensive benefits. We saw that slide. It has a lot of things to do with actual procedures or, testing and things like that. But is there a place, or is it included, to increase the social service network around the whole treatment of the patient?
That's really what the Care Coordinator Program is designed to do under SB 562, where every member, every Californian, every resident will have a medical home, a place where they can go to get assistance navigating the system, where their administrative tracking will be, where they can have the medical records accessible. So to us, that really does fulfill that function of creating a set of support services around those, and then we eliminate the means testing that currently exists in Medi-Cal for those in-home support services. So we also expand people's ability to get health care or get those services that they're currently getting only for low-income folks every Californian would have access to. So we do think that we can achieve some of that, some of those ancillary services and efficient spending on those services through our Care Coordinator Program.
And that's included in the
that's included in-
estimates. Okay.
Can I add to that? So that's definitely a big investment and a quality that is very strong in this proposal. And the field is rapidly evolving right now as we speak. In California, you may be familiar with the Whole Person Care Initiative and taking a look at how we spend our Medicaid dollars and realizing that many of the afflictions of our chronically ill patients that we're dealing with and confronted with are rooted in social determinants of health. And so that puts a new advantage to having a single-payer system, because we're going to have to rapidly think about how our healthcare system interacts with our housing system, that interacts with our mental health system, and that interacts with our transportation system. As an example, if you want to fight diabetes and obesity, you really have to look at our transportation partners who decide where public transportation is going to go, or where sidewalks are going to go, or where bike pathways are going to go. So this is going to force a new kind of collaboration, but what better way than to have to communicate with a multitude of different payers with varying degrees of motivation around dealing with non-medical things than to have a single-payer government entity that is concerned about the health of the population and that can work in a collaborative mode with these different disciplines.
Mm-hmm. And I agree with you, and to the extent of the services. I had a bill last year that got vetoed that actually had women misdemeanors getting transportation, getting the services, getting off substance abuses, and all of those things through existing funding, and it got vetoed. So you can see where our state is on that. Okay, quickly, I am confused, however, about the estimated reductions in administrative costs in hospitals and physician offices, how that would translate into lower health spending. The proposal was that physicians and hospitals be paid at Medicare rates, and estimate the savings from that proposal. If physicians and hospitals are able to reduce costs by laying off billing-related staff, how will that result in reduced costs for consumers if the providers are still being paid Medicare rates? So that outlay is still there, but how does that translate? The only way I can see that working is if ultimately the proposal would be payment rates even lower than Medicare. Am I missing something?
Okay, so in our proposal, and I didn't put up the slides because I wanted you all to look at me. But if we go to table 7, which I guess is what you're referring to, we have 3 sources of administrative savings. And so those would be administration within hospitals, administration in doctors' offices and clinics, and then the private insurance. And as you can see, we break those out one by one. So that's administrative. Mm-hmm. Now, that's distinct in our categorization from the savings that would accrue through moving to uniform Medicare rates. So the uniform Medicare rates, so we have the administrative savings in hospitals, 1.3%. And we get that by saying we're going to save 40% on administration, which actually, is a low number relative to what we've heard, and so forth. Now, moving to the Medicare rates, as was referred to, moving to uniform Medicare rates would mean a rate increase relative to Medi-Cal, and it would mean a reduction relative to private. So there is certainly an issue that Dr. Tarzynski raised on that. On the other hand, we have to recognize that when, as Dr. Tarzynski also mentioned, when the physicians' offices are going to be released from having to cover these administrative costs and the time spent, that will enable them to also bring in more patients. And so though the rates relative to private rates are going to come down, the amount of time devoted to billable hours will actually increase. And we will have more patients coming in because everyone is going to have decent care. So we think that on balance, physicians' income will not be hurt by this measure. And I think we'll be able to show that.
Once you open up access like this, a lot of physicians will be willing to see patients that they're not seeing now. You will get control, asthma, heart disease, hypertension, diabetes, other chronic illnesses. Right now, there's a huge cost because these patients aren't being seen with chronic diseases in regular primary care where these chronic diseases can be managed. They show up in emergency rooms. There's a much higher hospitalization rate for these patients because they're not under regular primary care where they're getting continuity of care. Opening it up like this opening up that type of access to physicians who would be accepting more patients like this will over time reduce emergency room visits, reduce hospitalizations and admissions, so they will cut costs that way. It may be a little bit of an upfront investment, but over time there will be savings because the quality of care will improve and you're not going to have a lot of emergency room visits and hospitalization rates. They all will go down.
How many
I was just going to add that we can assume that doctors are going to work the same number of hours they're working now under a new system, but they will not be spending the hours on administration. So there will actually be more clinical hours available to them, as Steve says. And so we talk about the physician shortage. Well, the best way to create more time for physicians to do clinical treatment is to eliminate their administrative time, and 562 does it.
I mean, is there an estimate on how many people would actually be laid off or removed from the system?
So as I mentioned, in the health insurance industry, right now the state employs about 147,000 people. And if you take these numbers that we have, this estimate of administrative savings, that would mean roughly half of them would get laid off from their existing position. The other half could be moved into this administering the state program at twice the level of efficiency. And so what we then work through are ways through which to either the people who are close to retirement, move them into retirement with a wage guarantee until their pension kicks in, and secondarily to move people, if they so choose, into comparable type positions in the state administration. And so we actually worked through some details on that, and we looked at outside of the healthcare, what are the kinds of skill sets in other areas of state administration in which these people could easily move. And so what we found was that of those positions, the demographic of people who are in the age range of 60 and over, old people like me, that's about 77,000 people. And so that over a 3-year period, we think we could move, if people wanted those jobs, into those other jobs. And in addition, we also provide for retraining for 2 years of wage insurance, pension guarantees. And through that, as I said, there are costs. And the costs would be, I think, in the range of about 1% of system costs for 3 years to move people into a good alternative situation.
And they'll never lose their health insurance.
And I'd like to drill down on that question to the delivery system, because I heard you say, well, what about cutting down on Medicare rates because a hospital doesn't have to have as many billers or, dealing with all the paperwork. There are so many demands at the point of delivery, at the point of service right now, that creative thinking is there around how to make adjustments. And I just want to give you one example. The electronic medical record, technically, that ends up, there's a whole lot of issues related to that. But from a work standpoint, it takes away jobs because all of a sudden you don't need staff to deal with files and retrieving files and things like that. It's all electronic. But what we've done at Asian Health Services is we've taken and looked at the pool of folks that are working in medical records and been able to shift responsibilities around interpretation, around cultural linguistic approaches, and around community outreach and health education programs so that there's redirection and with a little bit of retraining. And hospitals are in the same situation where as we begin to recognize how we need to move beyond the straight medical model and how we need to address non-clinical issues that actually, will influence whether or not people need to come into the healthcare system, then there is going to be a new workforce that ends up evolving from that. And we are at a limited capacity currently within most of our communities because most of these happen to be social services that don't get the type of public interest in policy setting, and that we need to actually move to creating and strengthening those kinds of resources within our communities. And again, that's what the single payer would do, in that it would be able to consolidate a lot of the savings, being able to support this evolution of the way we practice medicine in not ignoring and saying this is a doctor's office or this is a medical office. We don't deal with that problem, but actually integrating our approach at the point of service level so that we can provide better care.
All right, I'll just ask one more question. I'll save all my others for later because I don't want to take up all the time. I looked at Canada in Great Britain, and we have lots of studies based on, how they've been navigating and some of the ups and some of the downs. Administrative staff in Canada and here as well are primarily women. We have a lot of women who work in that capacity in healthcare now, doing the filing of the claims and handling denials and things like that for their doctors. They were laid off, and physicians' salaries on average were cut. In California, we are so low on the amount of physicians who actually take Medi-Cal. We need so many more. So if we estimate about a third are medical providers, that leaves 2/3 of providers are not Medi-Cal providers. So 2/3 will see a cut in pay. So those physician salaries in Canada were cut to half of what a primary care doctor makes in the United States, saving money up front. This being the case, what will happen to nurses' salaries? Because when I looked at Great Britain, their starting salary is $22,000. We don't want to get to that point. So how will clinicians and other salaries be affected as well, since we're laying off people, cutting other salaries?
Well, we're not cutting any salaries, and as Dr. Pollin said, there's plenty of money where the physicians will actually not suffer a loss of income, and certainly the registered nurses will not either. Because the problem is, what we're doing now in the current environment is we're restricting care in order to save money. We're Americans go to the doctor less than the average for similar countries in the world. We have shorter length of stays. We use less health care now, and a lot of that has to do with the barriers to care. If you look at these international comparisons that the Commonwealth Fund and others have done, they will tell you Americans use a little bit less health care than average, but we pay a lot more. Our problem are the prices, not the salaries. And the doctor's income will not go down because they won't be paying $80,000 a year for billing clerks. So that is a huge savings for them. Therefore, what we're able to do is actually maintain provider salaries because we put everyone in one risk pool. We save on prescription drug cost, we save on administration, we save on delivery. All those savings Dr. Pollin talked about enable us to then provide comprehensive benefits at current salaries with those savings. That's the difference. Then what we have in this country is we spend so much on health care. There is plenty of money if we spend it wisely. If we get our money's worth, we can cover everybody.
I'll save mine for later.
So we've been through 45 minutes of questions thus far, and just wanted to ask the panel if you would be willing, since we have a few more assembly members, to ask questions, and would ask those who are in the audience today, if at all possible, not to applause, only in that it's delaying lunch for you primarily. And but with that, as long as you're okay with a few more questions, I found this quite substantive and helpful. And so next we will have Dr. Wood.
Yeah. Thank you, and thank you all, everyone on the panel. I appreciate that. I want to go back to just to follow up, Mr. Lighty, to what Assemblymember Waldron was just asking. And I'm sorry I caught you mid-bite. That's okay. If I had one, I would eat one too. But, you said, we'll save $80,000 a year per office in billing. Those are people's jobs. So where do those people go? Because you talked with Dr. Pollin about the 150,000 state employees. You saying 150,000 people?
People in the state of California employed is in administration of health insurance. Yeah.
I think that number, it must be low. Dr. Tarzynski, I know in my own dental practice, I had two people. There are 25,000 dentists in California, or 30,000 dentists in California. I had a moderate-sized practice. I have to believe that 150,000 number is much higher.
Yeah, no, that's for private health. The private health insurance and related activities from the U.S. Quarterly Census of Employment, the most recent data, industry-wide figure is 147,757.
Do you have, what is your thoughts?
I don't have those numbers in front of me, but I certainly, yes, jobs will be lost because of that.
Okay.
But new jobs will be created. And the question is, how do we make a transition in a humane manner? Retraining, early retirement, sure, but that's a fact. I mean, yes, it's going to happen because the system will be more efficient, and people are employed right now in a system that is helping make it are only there because it is inefficient. So, yeah, but there also will be new jobs created.
And I guess that's my point, because it's not going to be an $80,000 savings per office, because those people will still be a part of the healthcare system in another position. Is that a fair characterization?
Yeah, it's one thing to say, the physician's office will not bear those costs anymore.
But the system still might. If
The
these other
system
people
will
are
bear a smaller
proportion,
yeah. And then there will be jobs lost, and that's why I've gone through some of these proposals for a just transition for those people, which I do believe in any final bill should be an important component of the overall bill.
Thank you. Okay. Thank you. Just, I think the other, and another follow-up to what Ms. Waldron was saying about services, and you talked about what we learned in our very first hearing was that countries that have single payer spend a lot more on social services, which relates to the health outcomes, the greater health outcomes. Things like education, like housing, like meals, some of the transportation issues there. But that really isn't addressed by a care coordinator, in my opinion. So if we're going to get those better health outcomes, where does the additional money come from to do that? Because that is not exactly the way it was presented to us by the Commonwealth Fund.
Well, I think we have to understand, first of all, that the present system has no ability to do that. So you have to compare the present system to the alternatives. And so you're absolutely right. What happens in European countries is they have a high tax environment, usually through value-added taxes, which are a kind of sales tax, and they comprehensively fund social services. We, on the other hand, in the U.S., fund those services through private spending. We, either our employer provides benefits or wealthy individuals buy them on their own, or we get tax subsidies to purchase some set of those benefits, which in general are not equivalent to the Europeans. Just as Dr. Chen says, the social determinants of health are the primary driver of health disparities and inequality. We know that 68% of Americans have 2 or more chronic conditions by the time they're 65. That means they're not getting the preventive treatment and the ongoing care that they need. And that has a lot to do with poverty, inadequate housing, nutrition. So we can't just talk about how do you address the social determinants of health. The question is, how do you eradicate poverty? So we have to go kind of 2 levels back, ultimately. And that is obviously beyond the scope of SB 562. What we can do is we can eliminate means testing that currently prevents people who can't afford it from getting the benefit. And I do think we should be a little more ambitious. And I would encourage the legislature to be more ambitious. We can create a healthcare system based on our values. We favor integrated medicine. We favor alternative therapies. We favor support services and broader social spending. We favor a transition so that people lead healthy lives, not just get medical care for disease. That's what's possible here. If you reorganize the system in the kind of way that 562 envisions, we can take democratic control of our own healthcare systems and address these problems, I would argue, Chairman Wood, more effectively. We're going to have to address these problems. The question is, what system can best address them? Is 562 comprehensively perfect on these questions now? No, it is not. Is it the best foundation to do that? We believe it is. Yes.
And just to be clear on the care coordinator, in fact, yes, the role of care coordinators, also labeled patient navigators, also labeled community health workers, also labeled case managers, a social service person. There's a whole field right now that's expanding. And that is, as Dr. Tarzynski was mentioning, that is an area of creative job growth that's occurring within the health industry. In that it's seen as a definite component that needs to be addressed. And so that's going to be happening, and that'll be an area for focusing, retraining, and so on. But it also begs the point that I think Mr. Lighty is bringing up. It's better for us to be cognizant of that and recognize that there's a whole other series of interactions and values that need to be brought into our public policy around those social determinants that include education, as you're pointing out, and include, job training, and include areas that will keep people, bring people out of poverty and out of the disparate problems that they're facing as subpopulations within our community as a whole, and better to be interacting collaboratively on that between systems that are resourced and very committed to overall improving the health of the community.
Okay, great, thank you. And I'm kind of all over the board here, so I apologize. That's the way my mind works. So as we, on Monday, we heard from folks related to how we would potentially get the waivers for Medicare, how we would potentially get waivers for Medicaid. We heard about, like Mr. Fountain talked about, the challenges that we look at related to the Constitution and the GAN limit and Prop 98. We saw there's a lot of things that kind of all have to stack up to make this work. And so what I get the impression, and it's not everybody, so please don't characterize it this way. There are people who believe that the passage of this bill will lead to an overnight everybody has care. And I think we all know that's really not true. I don't see how that could happen. Dr. Tarzynski talked about, and mentioned, which was also mentioned on Monday, the time it will take to actually get waivers is significant. So as we look at, and one of the things that really isn't addressed in 562 is we've talked about transition in parts of it, but there's really not a transition plan in there. So what do you reasonably expect as a time frame from a passage of a single payer bill in California to the point where people actually have coverage in the way you envision it?
We agree there is that transition period, and that's why we've asked Dr. Pollin to drill down and examine those issues more specifically to figure out the costs as he's described today from the job. Maybe there are other costs as well, and also timeline. As I mentioned earlier, the bill does envision not full implementation until the funds are certified sufficient to operate the program. So that's the trigger where we go live with Healthy California, is the funds are sufficient. That's a determination ultimately made by the board with advice. So that's where we stand with the bill language today. It is true that we're not going to flip a switch and have guaranteed health care. But I think what's important is that the notion that we should just wait for federal statutory changes is highly problematic. One, because we don't need statutory changes. There is existing statutory language about states' ability to administer Medicare. I know you had experts who thought that was very limited authority, experimental, or in some respects, but it does exist in statute. Dr. Pollin talked about the 1332 waiver provisions, very broad, very clear that those federal monies can be redirected from subsidies to funding. And you've got 1115 under Medicaid, which is we have an existing California waiver. The lawyers we've talked to who used to work for CMS believe we can expand that. So we're more hopeful about that. We also believe that there are, as Senator Kuehl has said, ways for the legislature to deal with the GAN and Prop 98 issues, and we would like to do a deep dive on that with your staff, other policy and legal staff in the Assembly. So our view is that we can either sit by and let the Trump administration determine what healthcare Californians get by not even trying to get waivers, not even calling them on their opposition to a waiver in this case that would be fully compliant with all the statutory and administrative requirements. And if they deny it, we believe there's a basis for litigation. We think it's worth the fight. And that's a political choice. Realistically, if the Democrats are able to take control of the House of Representatives or the Senate, then the political environment changes dramatically. What we have done with SB 562, and we've been criticized for this, we have not written a 140-page bill like SB 810 because we believe that the federal dynamic requires a certain level of flexibility. Lay the foundation, set the benefits, set the financing, set the policy framework and foundation and basic principles for the program, but give the board the power to respond to the changing federal circumstances. A long way of saying we don't know how long the transition is going to take, but we know it'll be shorter the sooner we start.
So just to clarify, we heard that this would require a change in federal law for Medicare trust fund. Do you disagree with that? Because it sounds
Yes.
like you do.
Yeah, we do. But there's two things to point out. In the bill itself, the provision is we're going to apply for these waivers, we're going to integrate the benefits, and we're going to integrate the monies. We also have a provision that says we're going to make sure that everyone who's eligible for a federal program, who's in California, applies and enrolls in that program and gets the benefits for that program. We also specify that we will pay the premiums for Part B coverage, and we will pay the Part D coverage for Medicare. And the study shows we'll have the resources to do that. So we are, applying for the waivers and believe we have a statutory basis. And William Shao is actually the one who pointed the way to these processes, right? And then if we can't get the waivers, we have the ability to create a parallel structure so that we can integrate those payments as much as feasible without necessarily the waiver. So we have a contingency plan, and we have a process to seek the waivers.
Okay. Looking at financing, and thank you for the answer. Thank you. And around the question of reserves, and do Dr. Pollin, have an estimate of what you would consider a prudent percentage of reserves, and roughly how much money in reserve would we be able to need to have to account for these fluctuations that are going to happen in the natural doings of our economy in California?
Yeah. So let's say in today's dollars, the system costs, on average, in an average year, $330 billion. And so, if we just take the methodology that I briefly described before, which says you look at the range around the average and the revenue coming in. So if we say that, in a very, very good year, I said 4.5%, but let's say it's 5%. So that would mean we would need another $15 billion in reserve to cover. That would be the good year, up 5% to cover the down year of 5%. So we would need something in the range of $15 billion relative to a $330 billion system.
And where would you see that coming from?
So over time, now let's not talk about year one. I'll mention year one.
So you wouldn't propose having sort of cash on hand?
Yeah, I would.
And how?
Yeah.
So how much?
Yeah.
And how much?
So basically, let's take a 10-year period, okay, and then I'll come back to year one.
Okay.
So in over the 10-year period, if we believe that long-term trends are showing us something, so some years we go up 5%, some years we go down 5%, and we need $330 billion per year on average. So in the years when we get, instead of 330, we get 345 billion, or let's say 350 billion. We grabbed the 20 billion that we don't need to fund the system, and we put it in reserve. And that would be enough to cover the years when we go down from 330 to 310 in revenue. So that's the long-term funding that would be adequate. Now, that does not answer the question that, let's say we start out in year one, and instead of raising 330, right in year two, we're down to 310. So that means that we would need to, for year one, we would have to have this additional 20 billion in reserve. So we would need to expand the first year revenue to cover that. But over time, the system funds itself based on the average level of tax or fee revenue. It's just that when we have the good years, you can't say, oh, great, here we have extra money, let's start spending it. You would have to put it in reserve.
And I guess I've read your study multiple times.
Thank you.
And
I'm sure it was great reading. And
each time you pick up a little bit more. But it left me with questions. And one of the questions is, it feels like, and I didn't hear much mention of this. You talked about the 2.3% gross receipts tax, but there is a 2.3% sales tax,
right?
Which is out there as well. So, but we'll make sure that didn't come out as you talked about. We talked in detail about gross receipts.
Yeah.
So this feels to me more like a snapshot in time.
Yeah.
And so my question is, we know because of the Republicans' tax plan that's supposed to help us all, that one of the things that's already being talked about is a decrease in Medicare, a decrease in Medicaid. We know that over time, in addition to this snapshot in time, costs in every system in the world, whether it's single payer or not, continue to rise. Period. It's not static. I mean, I go to the grocery store and things are more and more expensive. So I'm wondering, and I haven't even factored in the fact that we are enjoying an amazing expansion in our economy here that isn't going to last forever. So if we have a dip in the economy, if we have reduction in funding from the federal government, if we have increased costs, where do we get, I don't know that static up and down of just what you're talking about there is enough to cover this. Where do we get the additional revenue? How do we do that? Because that's what I'm struggling with in your analysis.
Mm-hmm. So yeah, you're absolutely right. What our study shows basically is a snapshot, but it's easy to incorporate. So the fact that the economy will grow over time. We will, by the way, we will have a recession. I don't know when it's going to be, but we always have recessions. That we have not abolished recessions. So there will be a recession and revenue will go down. And it won't be the first time, and it's happened many times. It happens in every single country that also have these publicly funded healthcare systems. So yes, you need a reserve fund to cover that. Over time, on average, the U.S. economy, advanced economies, grow. And through growth, we will generate additional revenue that will be sufficient to cover the growth in the population. Now, you also said costs will rise over time. What I'm suggesting is that costs will not rise over time. Costs will be controlled. Costs are rising. And by the way, so right now in the U.S. economy, we're paying about 18% of GDP for health care. And if you look at the CMS projections, they show it going up. You know, with Obamacare and with whatever controls they had in it. This is completely untenable. They're talking, if you look at CMS projections, in 10 years we're going to be spending 20% of GDP on health care, 1 out of every $5. And other countries are at roughly half that. We're talking about $2 trillion relative to the size of our economy, and equivalent for California. So we must control costs. And I think that the system that we have in place, suggested through Healthy California, will enable there to be very significant cost controls in the area of administration, in the area of pharma, and in the area of reducing waste, this area that, you know, the Institute of Medicine has said is at about 20% of all system costs right now.
So you don't believe there will be an additional need for additional tax revenue, percentage-wise? In other words, you don't.
No. Not percent. Not in absolute dollars, yes, because the economy goes up, population goes up. But as a share of the economy, no. I think it'll go down. In fact, you know, one of the criticisms of our study is, how come you're not pushing down costs more so that they look like Canada or France? Under our proposal, right now, California is spending about 14% of state GDP on health care. Under our proposal, it's actually pretty modest reduction. It'd be around 12 or 12.5%, whereas, you know, the other advanced economies are at 9 to 11%. So actually, our cost savings, which I think are totally viable, are fairly modest.
I guess, and I'll go back to the earlier part of that, is that what I prefaced this question with was, we already know the federal government wants to reduce the funding for Medicare and Medicaid.
Yeah.
That means less money.
Yeah.
That's a lower number. So where does the difference come from over time? Because it's not going to be a one-shot deal. I predict it is likely to go down in increments over time. So where does the additional revenue come from to keep the system whole?
Right.
Does that mean increasing the taxes?
So now the public funding constitutes 70% of all spending. So it's $225 billion.
Right.
And okay, so if there are, you know, tax cuts that will lead to a reduction in federal revenues for Medicare and Medicaid or Medi-Cal, those would have to be compensated for through an increase in the state. But note that doesn't mean that overall tax obligations would go up. It would just mean that the tax cuts that were put in place to reduce federal revenue for Medi-Cal or Medicare would then just be compensated by an incremental increase in state funding.
Which would be additional taxes.
No, not on net. It would just be when your federal tax bill goes down, then the state would have to go up to match the losses of federal revenue. So on balance, it would be neutral.
And can I just add that, you know, your question, I think, underscores the complexity of, you know, this whole process, and you know, even beyond SB 562, you're asking at least, you know, in part a technical question, but then also a political question, because the pie It's only as big as the people support that pie. And so, yes, there's an upstream part of that battle as to why would we be cutting back on Medicare and Medicaid if, in fact, we have needs that are unaddressed, and an evolution of our healthcare system that really demands, more funding for those particular parts of our population, the elderly and also the poor. But in addition to that, for a long time we've known from a public health standpoint that we don't invest enough in prevention in this country. Anyone who's in healthcare understands that. We instead invest wholeheartedly in sick care and the consequences of our lack of good policy and investment in prevention. So that doesn't go away. We still need to deal with that while we're dealing with advances such as single payer that'll give us some more investment in being able to, and pulling in more dollars and addressing the downstream, but then also paying attention to the upstream issues. And we have to do that. In countries where they've been able to level out the cost curve, they have that investment in social services and many other areas that you mentioned earlier. And so we got to keep that in mind.
But Chairman Wood, if I could, quickly, we still have to address those things are going to happen if they happen. What kind of system do we have to respond? Does the present system, where so much money is diverted to waste, inefficiency, profits, marketing, is that system better able to absorb the changes at the federal level? Or is a system where California has designed our own, guarantees health care, it's under our control? So I think you always have to relate those. Politically, I draw the conclusion that Medicaid has never been more popular. Medicare has never been more popular. I err on the other side. I think we're actually going to successfully fight those cuts and expand those programs. That's where I think it's going to go.
Thank you. And then I just one more question. And first of all, and thank you for your patience. I do tend to dive deep into things, and so these are the things that keep me awake at night wondering. One of the challenges and one of the things we have heard and seen with countries that have single payer is a very different workforce. 70% of physicians in single payer countries are primary care physicians and 30% are specialists. It's exactly the opposite in the United States. So, and also in single payer countries, a lot of them, their education is subsidized in some way by the government, which allows for it, and in spite of what they do have lower salaries. I mean, that's every information we have shows that physicians in single payer countries make less money. That's what we hear. So how do you envision taking the transition to flip that 70% to 30%? How do we get there? Because we don't have the primary care force right now on the best day. And I get concerned, I represent a very rural district. We can't get doctors there now. We struggle with that. They have to fly in emergency room doctors for one of my hospitals in one of the most remote counties in the state, one of the poorest counties in the state. So where do the doctors come from? And how, I see Dr. Tarzynski nodding there because we've kind of had some of this discussion. This is a monumental shift in the way we practice medicine. So that isn't, and I know it's not considered in 562. So maybe this is just more of a commentary, but I have concerns about that because we don't have adequate doctors in the right places now, and so a system that is focused on sort of a one-size-fits-all doesn't work for me in my rural communities. We fight all the time for just our fair share of things. And so one of the things I liked about Senator Kuehl's approach was a regional approach to governance, because this is an extremely diverse state. So this one size, one way fits all, it's not going to work real well in my district.
Well, yeah, we definitely are not creating a one-size-fits-all. But imagine if in that rural area the Medi-Cal rates went up 20%, because that's what we're proposing. The Medi-Cal rate's going up 20%. How many more doctors would take Medi-Cal? Wouldn't that improve the situation? I agree. The current system where you've got huge graduate school loans, you've got a system that privileges specialist pay, that has created fewer primary care physicians. We work with the Physicians for National Health Program, like the Kappa docs. They see this too, and they still support this reform as the best way to address it. These problems exist. Current system, new system. This system is better able to address them in our view. It is not a one-size-fits-all by any means. And in fact, we think that the structure of it enables the board to set up administrative flexibility that could achieve some of those same objectives that the Kuehl bill did. But I would also, of course, want to hear from our physician colleagues.
Well, my daughter's a general pediatrician, despite her father's example. And she graduated with a medical school debt of $240,000. So there are some ways, or I think we need to, yes, all of this is very good, but your question and your point is important. We can't wait for that to happen. What can we do now? One of the things that the state could look at is similar to the National Health Service Corps, is making medical school education free if you go into primary care. And for every year that the state pays your tuition, you serve in a medically underserved area, rural, urban, whatever.
And much of what you're describing, Dr. Wood, it's kind of like, the drug problem, the opioid epidemic that we're facing right now. We actually have a lot of the answers, but we don't have the public policy that's aligned with effectively implementing those answers. And so it is with the health workforce. You have a California Future Health Workforce Commission that is operating right now as we speak and generating a lot of information about how to address the crisis that you described in your county. And I can tell you, quite frankly, number one, it's pipeline. It's recruitment. And we know that people that come from areas that are in rural areas, if recruited, if put in a pipeline program, exposed to the health professions and the dignity and the amazing gratification from the service that you can provide as a healthcare provider, that people do want to go into the health professions, and they do want to go specifically to come back to their communities, much more so than recruiting from other communities on a sustainable basis. And we need to extend beyond physicians. There are really highly experienced and qualified nurses and nurse practitioners and physician assistants who contribute to our team that does the comprehensive type of primary care that we're providing. Now, I'm almost probably speaking like heresy because I'm a member of the California Medical Association, but speaking very practically, that's what we need to do. We need to extend our primary care workforce. Otherwise, that ratio will continue to plague us with overutilization on the specialty services and not enough of the care that people actually need that can be provided in a very efficient and effective way. And again, routing it back to a single payer system will see a lot of those issues and a lot of how the healthcare workforce needs to be deployed and how it needs to be geographically spread and how it can also work as a partner in systems change that will address the workforce needs. Thank you.
Well, and I'll close. I know Dr. Rambula and I have been fighting hard for more money for medical education, and we will continue to fight that battle. But it is really, really expensive, and not just for physicians, but for nurses and dentists and everybody there. We have to recognize that it is one of the challenges we face if we're going to be able to deliver on the promise of a robust, sustainable single-payer system. So that's really my point there. But it's not something I don't think we can turn on a dime. So,
to be respectful and appreciative of your time as well, I'm going to try and cap us for 15 minutes more of questions, if that's possible. And then would like to ask the sergeants if we could get more water up here for the panelists as well. Next, we'll have Assemblymember Chu.
Thank you, Doctor, and I want to thank the panelists and everyone who's been involved in this conversation. Let me just state at the outset, I'm really disappointed I wasn't here earlier. I've attended every hearing of this select committee. This morning I had a long scheduled interview with my toddler, who's not yet 2, with a nursery school, which reflects the challenges of getting into nursery school in my city. Yeah, exactly. So we'll talk about universal daycare next. But I want folks to know I did spend 2 hours in the car listening to the streaming internet of this hearing, and I've gone through all your presentations, so thank you for that. Let me first start by building on some of the questions from Dr. Wood, and I just want to say I completely agree with Dr. Wood and Dr. Arambula and others that we have to invest in our primary care workforce, and I am a co-author of SB 562. I do think that we ought to expand this to think about that aspect of how we ensure really the future of what our workforce needs to be. There were 2 points that came up in your discussion with Dr. Wood I just wanted to clarify. I heard some discussion around the idea that there's not an expectation of a huge loss of jobs in the healthcare sector. And I know there was some back and forth about what jobs would look like in the insurance industry, but just so I'm clear, my understanding is your contention is that jobs are not going to go down. They may go down in the insurance industry, but overall in the healthcare sector, with the idea that you're going to expand access to healthcare, the number of jobs and the economic activity related to healthcare, you're not expecting to go down dramatically. Is that the point that I think you were trying to make?
Well, I don't think there'd be any reduction in employment for people directly involved in providing care. That is almost certainly going to go up because people will have more access to care, and offices will be able to spend less time on administration and more time on care. But there will be job losses in the area of administration, and that's why we've focused on how to provide a just transition for the people where they will experience job losses through the contraction of administrative costs.
Thank you. And I want to actually thank you, Professor Pollin, because we've all read your analysis. I've been citing your study, and it's great to have you here in California. And I also want to just note, if I have not really heard much by way of refutation of your study, and if there are folks who have a very different economic analysis perspective, it'd be good to hear, but I want to just thank you for your analysis. And Dr. Wood alluded to the Trump tax law that just went into effect. And this is a plan, as we all know, that provides massive tax breaks for corporations and the wealthiest of Americans. Your analysis of the types of tax policies you propose to California are obviously based on gross receipts and payroll and sales tax, but you didn't look at what we might be able to do in California if we were to raise taxes in those very areas where things were cut at the federal level, which I think would probably bring in tens of billions of dollars that might be able to obviate the need even for a sales tax, as you proposed. So you haven't looked at the impact of Trump tax provisions on what other options we could consider here in the state of California.
No, I haven't. But as we know, the primary beneficiary of the Trump tax cuts are corporations. Having the corporations pay less in federal taxes will then therefore make it easier for them to increase whatever obligations they would have under this provision.
And I have to admit, Professor, that's my perspective as well, that corporations in California that have seen tens of billions of dollars of cuts, if we were to ask them to go back to where they were on December 31st, that would be more than enough to make sure we don't have to actually charge a new sales tax to pay for what we're talking about here. Right.
Yeah. Right. I mean, and also and again, my job is not to decide how to raise these revenues, to give you all options. And so the way that we designed both the gross receipts tax and the payroll tax was to load it disproportionately on big corporations. As we designed both the payroll tax and the gross receipts tax, as I said, 80% of business operations will pay no taxes. Now, the other ones, they'll pay a 2.3% gross receipts tax, but as you said, that is basically matching up against the tax cut that Trump just gave them. So, on balance, they're coming out even.
And this is certainly a conversation I'm interested in, and without putting my colleague, who's the chair of the Rev and Tax Committee, on the spot, I look forward to the continuation of this conversation here in the legislature. Wanted to shift the conversation to drug purchases. There was a slide in the presentation on SB 562 suggesting we need to consolidate state drug purchasing, and I think a number of you know I've been trying to lead those efforts here in the Assembly. We have had now a 2-year bill, AB 587, that would require the over dozen state agencies that purchase drugs to actually talk to each other, because at this point they don't share information, they don't even know what each other's respective pricing is, they don't negotiate collectively. And that bill has gotten through the process, but it is stalled in the final Senate committee. But that being said, so I understand what the proposal is on your part. You're suggesting that we consolidate the buying power, not just of state agencies, but local agencies and every healthcare consumer and patient in the state. Is that right?
Yeah, that's fair. I mean, I think what I suggest in the study were two models. One, a domestic model, the Veterans Administration, and two, Canada, in terms of their having formularies and using their bargaining power to lower drug prices. They're quite successful. In fact, the number that we have in our study of a 30% reduction in pharmaceutical costs is extremely modest. We're looking at other countries, you're 40, 50%. They're spending less through using their bargaining power. So that is a huge area for savings. And it's proven to work in every single setting that it's used. So I don't know exactly. I'm glad to hear about the work you're doing. I don't know the details of what you're doing now, but it certainly is a very promising area. And within SB 562, that would be a fundamental benefit that would be gained on behalf of the people of California.
I would love if you could provide my office with some more information on that subject so we can think further about it. I'd like to ask the Health Committee staff if you could reference a couple of slides in the presentation which really jumped at me, and I have a few questions about them, and that was about the contention of the denial of care by health insurance companies. So I had actually not seen this analysis before that suggested that in the time frame of 2009 to 2011, a quarter of all claims had been rejected by the insurance companies. 15 million claims, 13 million claims, we're talking 1 out of 3. Californians are 1 out, it's an enormous number. And I didn't realize that this information is no longer publicly available. Can you explain, why is that information not publicly available?
Well, our view, Assembly Member, is because the study came out and the insurance industry didn't want the data available anymore, so the state agency no longer provides it. That's what our researchers came up with when they investigated it, and so that's why we use the independent medical review as kind of a proxy. But that is what happened. The industry shut it down.
Okay. It's not state law that we get this information?
It is not state law that this information be publicly available, no.
Okay. If we could go to the next slide, if that's possible. So if I read this correctly, you're essentially saying that millions of claims were denied, and of that, only 40% were upheld. So in other words, either, in the other 60%, a percentage was reversed, the decision by the plans reversed, or the appeals were overturned. Am I getting that right?
You are correct. And keep in mind that before you get into independent medical review, you have to go through the company's grievance procedure. That is a 30-day minimum procedure controlled by the company. Most of the monetary awards at the end of this process that are given are because of how the grievance procedure has failed patients. So this is the second step. First, they got to get through the grievance procedure, which is why we say it's the tip of the iceberg, because go through that gauntlet, still go through independent medical review, and still 60% are overturned, essentially.
Okay, then next slide. This is obviously payment denied for emergency urgent care. And then if you could just flip through the next few slides. I know this is about industry profits right. and what's not happening. And then to the tip of the iceberg point, we don't know at this moment what denials or what claims have been made that when they're denied, a patient decides not to appeal.
Correct.
We just don't know that
That's
answer.
what we don't know.
Do you have any estimate?
We don't. We don't actually have an estimate.
Okay, so the point I actually want to make here is I'd like to ask the insurance industry if you could respond to these last few slides. It would be helpful, I think, for us to know. about this data and whether this, I'm assuming this information is true, and I would love to get some verification on that.
And we can provide the researchers who did this project, we can provide additional material. This is a summary of their work. We're happy to continue to work with you and other members of the committee on this.
Okay. And then related to this, I know I've heard at least every Democrat on this select committee, and I don't want to speak for our Republican colleague because I just haven't heard this, whether this is a statement you would believe in, but I think every Democrat on this committee believes that health care is a right, that every Californian should have an access to health care, and that health care shouldn't just go to those who can pay or those who can pay a lot or those who don't get a certain type of illness. From my perspective, if that's the case, when we have a status quo system that allows for millions of denials, it seems to cut up against that idea that healthcare ought to be a right. Yes?
Exactly right. Exactly right, Assembly Member. And you can't have healthcare as a human right if you condition it where it can be denied, where financial barriers can prevent care. That's not a human right. That's something we buy and sell, and we only can do so if we have the money.
Different conversation. I know we haven't talked that much today about the rates of underinsured folks, but from my perspective, the ACA has been great in insuring millions of more Californians, but at the same time, we've seen millions of Californians who have health insurance for whom that health insurance is not enough. And Professor Pollin or others, I'm wondering if you could comment on the issue of the underinsured.
Yes, thank you. Like almost all the issues, maybe all the issues in our study, I'm not an expert. I'm relying on a lot of the outstanding research that's out there. And so I have this study, how well does insurance coverage protect consumers from healthcare costs from the Commonwealth Fund? And so I quoted those there different ways in which we can measure underinsurance. The one that we were using as our measure of underinsurance was the one in which we say these are people who have insurance, that 34% did not fill a prescription, skipped a recommended test, treatment, or follow-up, had a medical problem, did not visit a doctor or clinic, or did not get specialist care. 34% of the people responding to the survey were faced with one of those four access problems with having insurance. That's one measure. And just briefly, they have other measures that people facing medical financial problems or medical debt with having insurance. People received a lower credit rating, 39%. Used up all of their savings, 34%. Took on credit card debt, 27%. Unable to pay for basic necessities due to the health care costs, food, heat, or rent, 23%. Delayed education or career plans, 20%. These are people that have health insurance. So this is the problem. It is not just the issue of uninsured. It's these issues of underinsured. And when I said at the outset, when you were listening on the radio or at your meeting with your children, the legislative analyst study, I said I agreed with about 70%. The 30% that I don't agree with, unfortunately, is important. And one of them was that they don't cover the issue of potential cost savings. And the second is they don't deal with the issue of underinsurance.
Have you written on that? If you could provide that analysis, because we've all read the LEO analysis, and there are some very interesting things in it. But it'd be good to get your perspective on that. Yeah. Okay, I do know we're bumping up against the 1 o'clock.
Assemblymember Chu, may I just answer just one of your questions earlier? Where we got the data from on the independent medical review is from the DMHC financial filings from the insurance companies. That's the source of that analysis.
So then what happened after 2011?
No, I'm saying these financial filings that they've made with DMHC include the IMR information, not the claims denial information.
Okay. Gotcha.
That was the basis for the analysis, was those DMHC filings by the insurers.
Okay.
And then the only other thing I wanted to add, just to bring it home again on a very human level. So in my practice, I have two examples of elderly patients who are covered. They have Medicare, and one of them has Medicaid as well. Walker, needs a walker, and had to end up paying an additional $50 to complete the cost of the walker, and is we're using a cane and no walker because she can't afford it. Plain and simple as that. The insurance, government insurance, should still be, a positive step forward, but is underinsured in that regard. Another patient who has diabetes and hypertension, and every time I write a prescription for him, asks me how much is this going to cost because he has a high deductible. And I always have to negotiate with him as to whether or not he can actually afford that medication. Another example of some underinsurance. And so it's real, it's human, beyond the numbers, which you need right now to be able to make some kind of projections on how it is that we can bolster our insurance coverage. It's a very real issue on a day-to-day basis for people living with underinsurance.
Thank you. I do understand I'm bumping up against a 1 o'clock time frame that our chair had wanted us to respect. Let me just close with the following. I've been a longtime supporter of the ACA, and we all know that Donald Trump and his allies are trying to rip apart the ACA. But I also think the ACA has not been what we've wanted it to be, and as you've just been discussing for the last few minutes around our underinsurance rates, as well as the fact that we still have millions who are uninsured. And so this is in part why I have been a supporter of the vision of single payer. And I wanted to be on this committee because I really wanted to sort of test that hypothesis. And I really want to thank the chairs for many hearings of in-depth discussion about a lot of these issues that impact what we ought to do moving forward. But I will say fundamentally, my perspective still remains the same. We need significant reform. And I think the vision of single payer still makes sense. That being said, clearly we have an awful lot of details that we still need to delve into. Details either within this bill that is being considered or others, to think about what we do given the reality of Donald Trump over the next 4 years. How do we set up the roadmap? How do we think about cost control? How do we think about transitions? How do we think about revenues? A lot of questions. But for me, the fact that those questions are out there is not a reason for us to not engage intensely in this conversation and to figure out right now. Because the urgency of now, with the fact that we've got millions of Californians who are suffering because of lack of access to health care, is as real today as it has always been. So I want to thank you for the presentation. I look forward to many other conversations on this, and as I've been saying to every stakeholder involved in this conversation, from every part of the healthcare sector, we need solutions, and we need to act now. And so I'm asking folks, and I think we're all asking folks, give us your best ideas now. We're obviously having that conversation today with SB 562 and other proposals, but we don't have time to wait. Thank you.
In respect to this panel, I'd like to ask one question, just to really try and learn from your expertise. Dr. Pollin, in your Perry report on page 3, you said that we would need $106 billion in state funding to be able to reach the goals of Senate Bill 562. But within the Senate Appropriations analysis, the author's own committee, there was $200 billion that they said would need to be raised. And I'm hoping that you can help to rectify the differences and discrepancies between those two figures, and which assumptions were made within your study versus what was done on the Senate Appropriations analysis.
For one thing, as I said, I do like many things about their study, and again, one of my former students is one of the authors. But the fact is they don't fully document where they got their results, which I think it would be fair to say that our study does carefully document. So it's hard for me to know in full. In general, the fact is that they are not incorporating potential cost savings, whereas we are. So we agree that to cover everybody under the existing system would cost $400 billion. We're in total agreement with the Legislative Analyst's Office on that. But we're saying that we can get costs down from $400 billion to $330 billion through the various sources of savings that we've discussed. They don't engage on that question. Very briefly, I mean, they do have a brief discussion about the importance of having, for example, drug formularies, but they seem to suggest that that's not possible under HB 562, whereas, in my opinion, it's extremely viable. And so, you know, that's one example. They do not engage on the issue of administrative savings. So I would like it if they had documented more fully why they don't think you can go down from 400 to, say, 330 or thereabouts. That's my sense of it. But as I said, we do go through it, and you know, I appreciate you all reading it. I didn't know that anybody actually would read the actual thing, but I mean, my students never read what I tell them to read. So you can see very clearly how we get from 400 to 330. It's right there, and I would welcome my former student Robert Ingenito, if you're here or listening. Tell me where I went wrong. If somebody has a good criticism, I'm open to it. I think they're fairly conservative. It's a fairly conservative estimate, so I'm willing to stand by it.
And I don't want to follow up the question, but really, you know, much like we were discussing earlier, are those savings achievable day one? Are those savings that would, you know, change over time? And really what I'm trying to get at is how we would look at transitions or implementation.
Yeah, no, nothing happens in day one. We, as everyone has said, we do not flip a switch and all of a sudden we've got this wonderful system that works perfectly. No, there'll have to be a transition period. On the other hand, so in this example that I gave on this issue around the cost savings from improved service provision, as we've talked about, I'm assuming 5% savings in that area, whereas the Institute of Medicine said it should be 19%. So what I actually think is that we start in the range of 3, 4, 5% in year one. I think that's possible from what my reading of the literature. But I think we can, if there's really 20% or more waste out there over the course of a decade or roughly a decade, we can get closer to 20%. And that's one of the reasons why I think that the CMS projections for rising healthcare costs, you know, the curve continually to go up, I think that is a major way through which we can actually get the curve to go down, recognizing that there is tremendous waste in the system. We will not get at it all in year one. Maybe we can get to 5% in year 1 or 2, but over the course of a decade, through a much more efficient system and much more careful monitoring, we should be able to get more savings. So that's why I think my estimate of 18% savings is probably pretty conservative.
And with that, if I can, I just wanted to thank the panel for your endurance and ability to answer these tough questions. We are going to take a break with this committee now until 2 p.m. I would ask those who are in the audience now to take everything that we have and to come back when we begin again at 2. Look forward to having you there.